Hello from Thessaloniki. This is the fourth international meeting on minimal invasive extracorporeal technologies organized by the society, MiECT. And it's a big pleasure for me, a great pleasure for me that I have here, as always, key opinion leaders from all over the world that we will try to give an update regarding the MiECT's technology. So to start with my presentation, please. Minimal Invasive Extracorporeal Technologies International Society is now 9 years as the main body that is dealing with this innovative and very effective technology. And as you see here, despite all the years of COVID, we were involving, and we have reached now to have roughly 450 members from 49 countries from 5 continents. As you see from the centers map that we have in our website, it is distributed mainly in Europe, though we still have centers that are in Asia and Northern America, and this is something very significant for the society. And in overall, what we are presenting here is a multidisciplinary society comprising not just perfusionists, but anesthesiologists, cardiac surgeons, as well as other people from the scientific community and the industry. So throughout these 9 years, as you see, there are a lot of events organized by the society, and we're discussing about the update meetings that have started 5 years ago, and every alternate year that they come after the big event of the society, which is the symposium. And throughout these update meetings, key opinion leaders have given a lot of lectures and a lot of updates regarding this technology, and that attracted, as you see, a lot of online viewers, because this is a hybrid event. Actually, this is an open board meeting, and as you see here, 125,000 views already from these meetings. And don't forget that our symposia are very popular as well. Just the second symposium after establishing our society attracted already 324,000 views. So this is a very big success of this society that is broadcasting through the CTSnet its events. And of course, that was 2 days ago when I gathered all the slides, and I went to the MiECT site to see how many people were waiting for the event. And as you see here, more than 11,000 people visited the website to see the data and the details and the program of this event before having the event already. With this, we come to today's event, which is hosted in Thessaloniki, which is the seat of MiECT, of the society. And as always, in this room where people are discussing and presenting, we are hosted by the local School of Medicine, Aristotle University of Thessaloniki. And as I say, we have with us the companies, and as you see here, we have merged with all these peoples to go for this broadcasted event. And we are about to discuss in this meeting the current status and perspectives of MiECT, what is the research and development regarding the industry forum, the 2 trials, comics that has been completed, and the MiECT study, which has already been launched. Of course, what are the clinical news from MiECT? And as I say, due to this online event, we keep giving all the news, all the updates, and we also try to form the future for this event. With this welcome and introduction, I want to pass on with the moderators of the first session, because we have no interval, no break. The schedule is very tight, and I urge you, whoever wants to ask any question or have any comment, he can use all the multimedia that we have, the social media, the chat, everything that can give us the information, so we can comment at the end to what is bringing to the social media. So thank you and welcome.
Thank you very much, Sir Kyriakis. It's a pleasure to be here today to be involved in the fourth update meeting. Moving right along, back to Dr. Anastasididis. He's going to give us a talk on MiECT and basically what's next for MiECT.
Thank you. Cyril is the president of the society, and he's co-moderating with Mike Van Driel, who is the director of ECT from Medtronic. And I'm really glad that these two great men are moderating this very significant session about the current status and mainly about the perspectives of this technology. So I will try to bring to the audience what's next regarding MiECT. So if I can have my slides. Right. I will start saying that this technology has been emerged from the 80s when the ECLS was brought into clinical practice and brought with it a lot of technology like the closed circuits, the centrifugal pumps, bonding circuits, short tubing. And so at the late 90s, the mini CPB design has been introduced into the literature. And as we keep saying, two centers, Regensburg and Paris, first tested, and we have the first results 2004 with this paper from Regensburg presenting the very first efficient results from the use of MiECT. Now, as far as the literature is concerned, this was the biggest meta-analysis in the literature some years ago, where we found that it's not just the morbidity that is reduced with this technology, but mortality also comes with it when we are referring to a big population, to a lot of patients. So with this background and with a lot of data that had been accumulated at those years, back in 2014, as I have already mentioned, 9 years ago, we have founded MiECT, this society, which from the first beginning, as you see here in this expert consensus meeting in Bern, managed to give chaos from order, defined MiECT, and emphasized that MiECT represents a strategy and not just a circuit, and also it mandated a teamwork approach for having the maximum benefit, classified the types of this technology into 4 generations. And of course, the fourth type is the modular, the hybrid circuits that for the first time at those years was brought up into the literature, even though they had been in the clinical practice a couple of years before that. And since we were discussing at those years about the efficacy and the safety of this technology, I would say that both of them, and especially safety, comes with the modular MiECT systems. And that was a breakthrough into the literature because there was no doubt that this technology is safe, and we didn't have any discussions in the meetings after that if we can go for this technology in a routine practice. So throughout the years, MiECT was represented in several congresses, as you see here, And of course, in journals, as you see here, and newsletters that have been distributed from the society, but mainly all the research and the paperwork that has been done by MiECT's members managed to be introduced into the guidelines. And as you see here, guidelines coming from MiECT, and the ACTA recognized MiECT significantly. The same 2019 joined the ACTA and EBCP, and a couple of years ago, even the American societies, MiECT, and the Society of American Blood Management also recognized the significance of MiECT technology. So with this background, I will try to answer what has been asked to me, what's next regarding MiECT. So first of all, what I would say, and what very significant member of our society, Rob Baker, Professor Baker from Australia, is keep bringing is the data. We need more data to manage to prevail, and mainly I will focus in two key points that we found throughout the years. One is microcirculation, and we will have with us Chan Ince in some states to give us an update on microcirculation and MiECT, and also data in these two big topics. One is the coagulation that seems to have a huge benefit regarding conventional CPB, and also the patient blood management that had to, let's say, be in the forefront of this technology. Now, what will be next is the results from this trial, which is the biggest trial ever in cardiac surgery in clinical basis, where the conventional versus the minimal invasive extracorporeal circulation has been tested, and due to COVID situation and low numbers, we had to discontinue, but still this 1,100 patients are still enough to draw some conclusions, and we have already the results from this trial that have been submitted to be published, and I think there is a dedicated session later on to see what are these results that to me is very significant that have been produced. And I'm very proud to say that even with this stage, we still find that MiECT is a very beneficial and a very safe and effective technique. So after being forced to stop COMEX trial, we have the succeeding one, which is MiECT, and MiECT has already been launched, trying to be more in the real world. So we have included all the modern technology that has been integrated into the perfusion systems. And for this, we are also proud that we have introduced the term OPEC into the literature, which is optimized extracorporeal circulation. So now with MiECT, we are comparing MiECT in real world with whatever any cardiac surgical patient is accepted regarding perfusion. And MiECT is about to have results in 3 years with these participating centers. And I believe this will have a great impact, because after this, we will be able to produce class 1A results. So what also is coming, these are books that are dedicated into MiECT technology. And as you see here, they are both old. So what we need now, these were to strike attention from the perfusion societies, but what we do need now is a new textbook that will incorporate all the latest clinical, technical, as well as research data that would be useful for anyone that is dealing with this technology. About the meetings, we will have next year the 10th anniversary meeting, and I will disclose later on at the closing of this meeting that I hope this will be a big event, so as we will bring together, after 10 years, all the scientists that made this huge success, that we have 320,000 views already from 9 years ago when we were in Athens. About the clinical practice, what we're waiting is to be embraced by all the modern techniques like the minimal invasive cardiac surgery, VATS, as well as RATS, robotic, and all the transcatheter techniques. And as we have already discussed from the first update meeting 5 years ago with the former president of ISMICS, is that we need to collaborate as two societies so as we make it happen. So this still has to be accomplished. Now, regarding training, as you see here, we have industry that is leading and actually enabling us to give a lot of training and a lot of classes, either online, virtual, or hybrid, or even on-site. And of course, we should go for simulation techniques, not just wet labs, but dry labs. And we need to emphasize that this is very useful if we want to expand this technology. But we shouldn't forget that some years ago in this, 2 years ago in these meetings, the update meetings, the president of the EBCP, the European Board of Clinical Perfusionists, has started the discussions on this MiECT Academy that had to be included in the portfolio of the perfusionists, so as we will manage to have better educated and better trained perfusionists. And also, we shouldn't forget that 2 years before, we had, at those days, the former president of EBCP, Professor Wachba, who said that we should not just having academias, but we should integrate MiECT into the perfusion schools. And MiECT should be the stakeholder along with the industry, so as we will have ultimately the teaching of this technology into the standard perfusion schools, so it will produce perfusionists that will be able to integrate this into the clinical practice. So as far as this new initiative, I would say that what is about to be launched is a new platform that is regarding the massive open online courses, and our secretary, Polychronis Antonitis, later on will let you know what is this about. It's a digital library that we managed to have throughout the years, and we are about now to have a collaboration with EBCP. Already we're discussing about the CME credits and how we will be able to give these credits with what we have created here in Thessaloniki. And I have to disclose that this was a discussion we had with Mike Van Driel and with John Merkin when we were in Canada last meeting, and we are now ready to launch this new platform, and I hope that would be embraced by perfusionists through to all over the world. And definitely what is next for the clinical practice is, as you see here, about 850,000 cases per year throughout the world require surgery on CPB. And I would say that if ELSO is referring to about 1/10 of this workload, how significantly is the expansion of MiECT use to other continents and mainly other countries, as the targets that we have already focused, as you see, is Australia, South Africa, South America, India, Russia, Northwest Europe, and mainly what we said is we will try to take Manhattan after Berlin, because Germany started this technology, but what we need now actually is to move to the biggest market, which is about half market of the world in United States and Canada, where I believe this technology will give the way to be adopted in routine practice. Now, I shouldn't forget that, as I have said, the hybrid systems, modular MiECT systems, have brought safety and also versatility for doing all cardiac case mix. And what we would need is a plug-and-play devices. You see that we have this technology, and if this is handy, if this is easy for a perfusionist, and if this is accompanied but with all these inline monitoring tools, I believe that we will reach to the point that we'll be able to have MiECT as a standard practice. So to conclude, when that will be happened, Rob Baker, 3 years ago in the MiECT is live due to the COVID situation, that was a virtual meeting, said that we are here to the early adopters regarding MiECT, and we need time to go. But last month, there was a paper that was published in JAMA where it is calculated how far we should go from now on. And it seems that this is 17 years. This is the average for a technology to bridge the gap. This is called chasm. This is a Greek word. And if MiECT has been established in 2014, I would extend its initiatives up to 2031 to reach to the point that we will have people that gradually will leave behind everything, so as we will reach to have this technology into the written practice. And as it says here in the article, it's hard to change, but I believe that the guys that we are bridging the gap are ourselves, and this is what MiECT is supposed to do, so as we will find the weather to go there, because we all believe here that MiECT is a more physiologic perfusion, and this is mandatory to clinical practice and to advanced patient care. What we need here is the glue, and the glue to all this is, of course, our society, MiECT, and that's why I believe MiECT will ultimately prevail, but a lot of steps have to be done, and that's why I present this, so we will keep it as a record to see how much we have already been so far, and how big is the road from now on till the end that I hope we'll be able to go. Thank you very much for your attention.
Thank you. I think we have a comment from Dr. Sommer.
Everyone, I don't know if you can hear me.
Yes, can.
Thank you very much, Kyriakos, for this very comprehensive summary of what has been reached over all the years. And I think what is extremely fascinating, at least in my eyes, is the fact that the randomized trial is now almost ready for publication. As I think a lot of people were waiting for that, and finally it's the final proof of what the technique can actually offer. I also would like to comment a little bit on what you mentioned. It takes 17 years for a technique to become, let's say, the standard. But I think that there is a difference to make between the MiECT on itself and the fact or the impact it had over the years on conventional cardiopulmonary bypass, because we can also see there that there was a huge decrease in the volume which was used, that people became more aware about avoiding reservoirs or treating blood differently. So I think the seed has been brought to a lot of people that they should change their technology. And of course, MiECT will then be the final goal. which is probably a steep learning curve for some in the beginning, as it's a real team approach, as you say. But on the other hand, once it's actually implemented, I think you work really according to the best approaches. I would like to come back on what you said, what could be the future. Training, I would fully agree, is a very important issue. And EBCP is trying now to establish a quality platform for the accredited schools in Europe. I think that will be also a quite interesting project, and we are in full expansion of it at the moment. And of course, it could be very well possible that what you were just suggesting as having a teaching, that this could be implemented in future in the education or the standard education of perfusionists. And finally, I would like to ask you a question, as I was allowed to ask questions also, they told me. And that would then be, as we make a lot of advantages in the blood compatibility of the device, that means that we probably also can make advantages in some fields we haven't discovered in depth. And one of the things, and I probably suppose that Marco Ranucci will tell us also something more, is the fact on how we are actually going to work with all these monitors. You were mentioning there is a lot of monitoring available now. Luckily, there are also some new platforms on the market, which probably make it more easy to implement them. But the final question will be, are we still be able to absorb all this information? And I think what Marco Ranucci has shown in his latest paper, that actually we should do multivariate analysis. I believe that probably some of the points which have not been really investigated would be the benefit on hemodynamic stability when you use a MiECT system. But I would like to hear your opinion about that.
May I answer? Thank you. So thank you, Philip, for your valuable input. What I would say is, first of all, I fully agree that training is first and the clinical is coming after it. But regarding all this contemporary technology, for me, it's mandatory. I also agree that this has been very, let's say, difficult to follow nowadays because there are a lot of tools, as I have already indicated. And that's why these are allocated to disciplines. I mean, the perfusionist is having his own monitors, let's say GDP, or guiding its perfusion, while anesthesiologist has point of care, coagulation, heparin protamine management, all the rest. The surgeon is doing his own supervision to what is existing, but definitely let's focus in perfusion. It's very important to guide your perfusion. It's not enough nowadays to go with blood pressure and with pump flow. So what I would say is to simplify what's the monitor about. And I remember what Mike Van Driel, who is next to me, was saying is just don't go that much to the GDP. If you educate your perfusionist to go with oxygen extraction rate, for me is still enough as the first step. I can go with DO2 or VO2 or DO2 to VO2 index, but oxygen extraction rate so far was not there. So gradually we need to integrate whatever the monitorings are giving us. And I agree with you that this needs some time, but I also go with what John Merkin and Marco Ranucci and me and Polychronis have integrated into the literature, that physiologic cardiac surgery is what we need, and we need to embrace all this.
Thank you so much.
Okay, well, I've got the pleasure as the co-moderator to introduce the next speaker. So Professor Alasawi is going to share his thoughts on and results on practice on results on MiECT in high-risk patient populations. And just privately, I've known Ashraf now for I'm afraid to say.
More than 17 years.
At least more than 17 years, if not 20. And I probably learned more about the whole concept around mini bypass from him than, in fact, I brought that all over immediately to Cyril when we started doing it in Canada. So it's a great pleasure for me to introduce Professor Al-Asawi in this presentation.
Yeah, thank you, Mike. Well, the topic of my presentation is the implementation of MiECT in high-risk patient populations. My presentation will focus on three main issues. First of all, what is a high-risk population? What is the rationale of implementing MiECT in that kind of population? What do we expect? And what is the evidence that has been brought up in the literature so far? Okay, I have to go back. It's too quick. The cornerstone to perioperative care is the preservation of homeostasis. This is something that surgeons had to learn by time. We're more focused on anatomy than physiology, but the introduction of MiECT has definitely shifted some of this focus. And preservation of homeostasis is the keystone to preserving physiologic reserves. And these physiologic reserves are depleted the more we have to do with high-risk patients. And once these reserves start to fade, we're facing morbidity, we're facing organ dysfunction, which later on, if we go further, ends up in organ failure, and at the end of the day, in multi-organ failure. So we have to preserve this physiology, and the way is through preserving homeostasis. And we know from MiECT that it respects physiology, that the nomenclature itself comes from reducing the physiological trauma inflicted by extracorporeal circulations. And now focusing on, if we put that to a challenge, then we most probably the effect will be most evident once we introduce or implement this technology to patients in whom these reserves are already depleted. So we're focusing on older patients, we're focusing on multimorbid patients, on patients with a high Euro score. And as I just pointed out, once the reserves are depleted, we're shifting from our main goal, which is an optimum outcome, meaning that the patient has no complications at all, no morbidities, preferably no transfusions as well. This is the main goal in order to minimize the risks for a long-term outcome. And once these reserves are depleted, we're facing morbidity, and at the end of it, we're even facing mortality. This is one of the early papers which concentrated on high-risk patient populations. It comes from the team of Kyriakos here in Thessaloniki. They had a prospective randomized study with a type 2 MiECT focusing on CABG in 100 versus 100 patients. And they defined them in that they did a subgroup analysis in which they defined high risk as an age above 65 or a Euro score 2 above 5, or an ejection fraction of less than 40% preoperatively. About 80% of their patients had one of these risk factors, and they could show that they had a reduction. When they looked at this subpopulation, they had a reduction in their ICU stay, they had a reduction in their ventilation times, and they had a 77% relative risk reduction for major morbidity, mainly focusing on myocardial infarctions and renal failures. One may question the age above 65, Euro score above 2, above 5%. But once you look at the impact of these variables in a univariate analysis, you find that they all had an impact on the incidence of major adverse events. And once you look at the sub-patient populations, once these are treated with a MiECT, they always thrive better than when they were treated with a conventional system. This is a publication from Sedar Gunaydin. He did another study focusing again on CABG, defining the Euro score above 5. And again, they found a reduction in their intubation time, in their ICU stay, and they had even had a reduction in their mortality rates. The group from Regensburg did a retrospective study, again focusing on the cabbage population, and they defined high-risk population as a logistic Euro score above 10%. We see that their logistic Euro scores were quite high, almost or just exceeding 20% in both groups. They found significant differences in post-operative lactate, in post-operative myocardial injury markers, CK, CKMB, and in creatinine. All factors that are related to the quality of perfusion itself. They also found a difference in their 30-day mortalities. However, this only stood true for univariate analysis. Once they did the multivariate analysis, they couldn't prove that point, but still they looked at 100 versus 100 patients. So most probably, if they exceed these numbers, we would have a significance there. Asking yourself, how do we find high risk? We said we're concentrating on octogenarians. The relevance of octogenarians, I'll point out in a few slides. We did a retrospective analysis in which we analyzed little more than 300 patients. Looking at those, we found that the MiECT group had a higher age, significant higher age, and a higher incidence of renal dysfunction, which is quite interesting because some of the other studies had advanced renal dysfunction as one of the exclusion criteria for MiECT. And then we saw that the 30-day mortalities showed significant differences in favor of MiECT. Low cardiac output was again in favor of MiECT, and reintubation due to respiratory failure. We had looked closer at the surgeons that were involved, and we couldn't find an impact of this from the surgeons. They were all using both types of systems. And when we did the propensity score matching, again, the 30-day mortalities were significantly different, and the incidence of low cardiac output stayed significantly different. The relevance of octogenarians becomes apparent when we look at the demographics in Germany. By 2050, more than 5 million people living in Germany will be above the age of 85. So this is a very, very aging population. The incidence of frailty is increasing. And of course, these patients have depleted physiologic reserves because of their age. There is another way of defining high-risk population through the risk of surgery itself, the complexity of your procedures. This is a retrospective analysis of annual outcome of patients in 2013, I think. I was keen to implement MiECT in all comers. And during that year, I did what I would classify as complex surgeries in 38 patients, 15 redos, double valves, triple valves, composites, aortic valve reconstructions. You see that the duration of surgery is substantial. The bypass time exceeded 2 hours, clamping times of a mean of 100 minutes. And what's interesting is that the incidence of an optimum outcome was 42% in these patients. What is optimum outcome? The optimum outcome for me is the lack of any complications and the lack of transfusions as well, because transfusions have a potential of a deleterious effect on long-term outcome. When we look at the Euro scores of these patients, and we find that a lot of those had Euro scores, or most of them had Euro scores exceeding 5% logistic Euro score, some of which them had logistic Euro scores exceeding 30%. And from all those patients, from the 38 patients, only a single patient died within 30 days postoperatively, resulting in a mortality of 2.6%. And what's interesting is this patient was really one with a very high logistic score, high risk. The relevance is when we define through complexity of surgery, then when we look at the SCS database, major morbidity increases with the complexity of surgery. When we look at the patient collective of mitral valve replacement plus CABG, we have an incidence of major morbidity of 35%, with the readmission rates of 30-day readmission rates of 16%. So these are significant numbers. This is another publication from the STS based on the STS database, in which they looked at 300,000 isolated CABG patients exceeding the age of 65 years. And what is interesting is first the number of 173,000 patients, which is the control group. These are the patients who did not experience any postoperative complications. That means that in isolated CABG patients exceeding 65 years, almost 50% had postoperative complications. And when we look at the Kaplan-Meier curves for long-term survival, we see that those who do not experience postoperative complications definitely have a significantly better outcome than any patient who experiences some sort of postoperative complications, which are listed in the graph. Now, in high-risk patients, in octogenarians, we are facing a challenge. We have a competitor. Those two guys are most probably among the greatest that tennis has ever brought about. And one of the reasons why they were so great is because they lived in the same era. They pushed each other. TAVR is not a knockout for cardiac surgery. It just tells us that if we want to implant the valve that's shown above, which most surgeons would think is better than the valves below, then we have to put more energy into getting better outcomes for surgical patients. So is MiECT a way of doing so? We did again on our retrospective propensity score matched analysis, comparing our savers to TAVRs. We came up with 68 patients in each group, aged more than a mean of 84, with a logistic Euro score exceeding 20%. And if you look, the 30-day mortalities were actually lower in SAVR. They were not statistically significant, but initially we wanted to publish this paper, including all TAVRs as a comparator. The publishers said that transapical should be excluded, which is somewhat irrational, because once you decide that the patient is going to go into TAVR, not SAVR, you will not change your mind once you go to transfemoral or transapical. Nevertheless, with including both groups, we had a significance, including only the transfemorals. We didn't have a significance, but at the end of the day, the numbers are still better. Rethoracotomies were equal, which is quite surprising. Major or minor vascular complications, of course, were higher in the TAVR group. Resuscitations were higher in the TAVR group. Incidence of new onset atrial fibrillation, of course, was higher in the when we used the MiECT. However, if I'm to operate an octogenarian nowadays, I would always resect the left atrial appendage, regardless if he has an atrial fibrillation or not, because I'm reducing the risk. This is an option you don't have when you do a TAVR. And the incidence of paravalvular leakage was, of course, higher in the TAVR group. I'm not saying that we're better. I'm saying that surgical aortic valve replacement in an octogenarian is still a contemporary solution. It is not something that you should rule out per se. What does the future of cardiac surgery look like? Well, in 2013, when I did these complex cases, I was quite sure that the future of cardiac surgery would be MiECT. 10 years later, I'm not so sure anymore, but I still have the hope. And I've just been taught that I should wait another 7 years, and maybe we'll get there. The only way of doing this is by pushing further, by analyzing our data, by not being satisfied with what we reached, but looking for tomorrow and into the future and becoming better with every step.
Kyriakos gave a certain date, I think 2031. Okay.
I was going by data and by scientific research that we need 17 years from the first time. So it's about
So at the MiECT update meeting 2032, we could actually discuss what was the. So what was the.
Well, thank you, Professor. And I forgot to mention that you are at the University of Göttingen, so I apologize for that.
Okay, you mixed that up, but I'm not a professor.
Well, that's fine.
That's another
You know,
point.
that's then okay, fine. You are in my mind, so. But I think the comments here are going to be done by Apostolos, who is the chief perfusionist here at the Aristotle University Hospital here in Thessaloniki.
Very good results. We normally use the modular MiECT system to all comers in our hospital, urgent cases, dissection, reoperatives, very high risk, high Euroscore, and we had 100 success technique. We have done all these cases with the modular MiECT system. So I strongly believe that MiECT stands on the top of perfusion because it integrates all the recent advancements in perfusion technology. I would say that represents the latest evolution in perfusion, overcome obstacles, technical issues, as well as safety issues. I strongly believe that the easy way to restrict hemodilution and to avoid anemia is the use of MiECT system. Having a good hematocrit is the precondition to have adequate oxygen delivery. It is well known that there is a critical DO2, and whenever the patient goes below this value, he is creating an oxygen debt, and lactate will go up. Production of carbon dioxide will raise up. SVO2 continuously decreases, and at the concept of goal-directed perfusion, we don't want the patient to be at the anaerobic zone, but we want to be on the aerobic metabolism. So MiECT improves head organ protection and reported benefits, not just hemodilution, blood bleeding, needs for blood coagulation, but also protection coming from microcirculation. We have done extensive research on microcirculation, comparing the two systems, and the results are significant with the use of MiECT system. So if we want to go from less physiologic perfusion to more physiologic perfusion, MiECT system should be in the clinical practice. We need the MiECT system not just for the perfusionists, not just to embrace this technology, but try to have a comprehensive and integrating approach to physiology, try to apply physiology, work as a team, use a strategy, the MiECT strategy, if you want to increase and to enhance your results. Thank you.
Very good presentation, Asher. One of the problems, well, I would say problem with the COMEX trial, we had a problem recruiting high patients with high Euro scores, right? But yet we see that, those are the patients that probably do the best. So kind of why would that be? Did you have an idea?
No, fortunately, the main bulk of our patients do not come with a high RUS score, because we didn't go out for that study and recruit new patients that weren't operating before. So obviously, the main bulk of our patients is not at high risk. And the problem is that a lot of MiECT users differentiate when they would implement MiECT. One of the biggest mistakes ever done in implementing the system was seeing it as a competitor to off-pump CABG. We are no competitor to off-pump CABG. Off-pump CABG has its population in which it will definitely thrive better than any heart-lung machine. You have a porcelain aorta, you will never clamp this aorta. You could go into assisted beating heart or something like that, but if you're well trained on CABG, you will always do off-pump surgery. You will always do an off-pump surgery. But that was a hindrance in implementing MiECT throughout cardiac surgical population. It was always, if you're reluctant to do an OpCap, do a MiECT. It's not if you think that it is better to use a MiECT than a conventional system, then do a MiECT. And this is quite difficult to get out of mindsets, because and then we have a tendency that once we are into this technology and we're maybe a few consultants or 1 or 2 consultants struggling among 5 or 6, you're a bit reluctant on letting the others doing it freely without being in control, because often surgeons think, well, this is the machine is a problem of the perfusionist. I don't have to change anything. I don't have to change my character, how I deal with others, how I communicate with others, how I react to others. Every intensivist knows that once you have an ECLS, veno-arterial ECMO, and the patient is out of volume, or there is a kinking of the line, then your centrifugal pump, which is preload and afterload dependent, will not work. So you either change the positions or you give volume. And you don't have time. This is something that you have to react instantaneously. Getting this message from a perfusionist on a MiECT to a surgeon performing surgery, I need to change now, not in 5 minutes after you finish your anastomosis. Then something else which is quite surprising is when we have a better drainage, we have less blood in the coronaries once we do conventional bypass. In MiECT, there's always some blood most of the time in the coronaries. When I do a coronary anastomosis, I only want to see the rim of my vessel. This is where I'm placing my anastomosis. I don't have to see the whole vessel, even if some blood is in there. When you do an OpCap, there is a shunt in there, so this is no real hindrance. But I am used to see the back wall of the coronary. I want to see the back wall of the coronary. So if the surgeons do not get in their mindset, I'm doing something for the sake of physiology and not for the sake of a program or a perfusionist who wants to use a MiECT or something like that, it is quite difficult to adopt.
There we go. Dr. Florhanger, understand in Rheinsburg, you guys have been using MiECT since 2000, sort of last 25 years, or 23 now, I guess, 23 years. There you go. What's your experience in high-risk patients, and are you seeing the same things that Ashraf is?
Well, I think it's not really more dangerous to run a mini bypass in a high-risk patient. Even if you have a patient with a cardiogenic shock, I would say we just do CABG with mini bypass. And you have a patient in cardiogenic shock and you do CABG, I would prefer mini bypass, because if you don't get the patient from the circuit, then you can leave it in the worst case. I think the main point is the surgeon has to be familiar with the system. If you get a young surgeon who is familiar with a conventional machine, then you shouldn't force him to do a mini bypass. I think it's not really more dangerous than to go with a MiECT system than a conventional machine. But we do just CABG, so we would never use for another procedure, because we stick also to a type 2 system, and if we do something else, we do conventional, because it's kind of philosophy. It comes from Alois Philipp, you know, and I support this philosophy. So, but for CABG, it's not really more dangerous. Also in high-risk patients.
Okay, thank you. So we'll move on with our next presentation, going on along the current lines of current status and perspectives. I'd like to introduce you to Serdar Günaydın, who is the Vice President of MiECT and Professor of Cardiac Surgery at Midline Hospitals in Ankara, Turkey. And Serdar is going to give a talk on MiECT, MICS on MiECT.
Thank you very much. It's always a pleasure to be here with my friends. So years ago, we were excited to use, let's say, MiECT as by ourselves and feeling lonely. And now with the increasing number of interested surgeons, perfusionists, anesthesiologists, it's very much enjoying and exciting for me to be here again. So thank you very much for the invitation. So today I'm going to talk about our recent experiences on using MiECT in minimally invasive cardiac surgery. So as you can see, when we check for the guidelines on MiECT, it's just turned out to be now class 1A, especially with causing less hemodilution in preventing and being one of the most important points in patient lab management. And also it's class 2B with the, let's say, the perfusion point of view, because you're using low prime, minimally invasive circuit. So it's a kind of part of the multimodality blood conservation program. And also with the recent guidelines, it's also class 2A and still one of the top important points inside the operating room to support patient lab management or ERAS initiatives that are going to be much more popular now in cardiac surgery. When we check for the minimally invasive surgery, it's becoming more and more popular. So, for example, I just gave a similar title talk 2-3 years ago, so we don't have that much experience at that time. And also, especially minimally invasive coronary artery bypass surgery, MIECT was not that much popular among the surgeons. And in the years, it's really going on acceleratedly, very high incidence, growing side. So most of the surgeons are now being interested to do some minimally invasive techniques, including valve and coronary artery bypass surgery. So when we check for the guidelines, again, it's on 2A, 2B, because especially in heart valve surgery, because when you use minimally invasive incisions, you have reduced blood loss or so less need of transfusion. So why not combine these two procedures? Because when we check for all those presentations, publications right now. So MiECT is safe to use in most of the operations, including cabbage, valve, also some kind of mixed type of surgeries. So we can use even in a temporary mini bypass surgery in closed shed, peripheral cardiopulmonary bypass, salvage operations. So it's becoming more, the experience is now very high and very much supporting us to be really brave to use in any type of indication. On the other hand, mixed minimally invasive cardiac surgery is also, as I've told, become very, very much, even more faster than the popularization of MiECT. And now most of the centers are doing, for example, in our center, we are doing nearly all valve operations under minimally invasive incisions and 60-70% of the cabbage by mid-cap surgery. Because is also when we have more and more publications, minimally invasive cardiac surgery, we see that, so there's especially less pain, less bleeding, and less need for transfusion. And not only cosmetics, but it's very much easy to have a good result in reoperations. So it's becoming also more popular in using in high-risk patients. So the best way is now we have very good techniques in perfusion, very good techniques in cardiac surgery. And then both of them have very good evidence to support. So why not use them together? But still, we have not that clear data, of course, to use both of them, because I don't think many centers are using both technologies at the same time. So we still need more clinical evidence. And of course, I believe that the strong interest I see among the young surgeons would support to use both of those techniques in the near future. And also, one of the most supporting points is that there are now patient-centric multidisciplinary approach in cardiac surgery. And in this sense, minimally invasive techniques are the most appropriate solution to use in those programs. For example, we have been using the active patient lab management program for the last 10 years in our clinic. And we work with a large group together, so we are accustomed to use as a multidisciplinary approach in also patient-centric target. And so we have very good results, especially we believe that when we want to do something significantly better, the only things you can choose from here is clearly minimally invasive surgery plus minimally invasive extracorporeal circulation. So if you can do both of them, you can make a clear difference in patient lab management perspective inside the operating room. And also we have now an actively acting the ERAS program. ERAS is also becoming more and more popular in cardiac surgery, as you may know. It's enhanced recovery after cardiac surgery. So cardiac surgery was the last discipline to start using the ERAS protocols. So the idea is very simple. You use multimodal transdisciplinary care improvement initiatives to promote early recovery of the patients undergoing surgery and to reduce complications, so promote an early return to normal activities. So the first guidelines for ERAS in cardiac surgery was published in 2019. And now the next updated guidelines will be published this year. And I'm also in this ERAS Cardiac Guideline Committee. And of course, we just overviewed the impact of minimally invasive surgical techniques and MiECT on ERAS patients that would have very much. So because in the ERAS protocol, it's much more complicated protocol than patient lab management. Again, these two techniques are the most important points to create some difference inside the operating room. So I just will show a very short video of our ERAS protocol in our hospital. So I'm working in a very large hospital, so one of the largest ones in Europe. So we have about more than 4,000 beds and 131 operating rooms overall, 25 cardiac. And we have 5 cardiac surgery subgroups. I'm the chief of one of them. So each subgroup is doing more than 600 cases. So overall, we do 3,000 cases. So in ERAS patients, we just do prehabilitation before just hospitalization. We just check them, prepare for surgery. For example, go to dietitian. And the very important factor is that we just demonstrated that 15 to 20% of those patients are already in malnourished position before surgery, and they don't know that. So dietitian prepares the patient from home for surgery with diet supplements or whatever. So we treat preoperative anemia before hospitalization. And so we call the patients for hospitalized. So we check all of them again, for nutritional support, anemia treatment, diabetic control, and before surgery. So until 2 hours, all clear fluids are available. And then so we do carbohydrate loading. And of course, inside the operating room, we do everything. But of course, the most important point is to use minimally invasive techniques. So pain is very important to help patients recover very early. So we do the erector spina block for all patients undergoing median sternotomy. So this, of course, we have been now applying this program for the last 3 years. Now we did more than 1,000 cases. We do also saphenous block with the adductor canal block to overcome pain in the early postoperative period, routinely for all those patients. And of course, the most important part of the surgeon is to create difference inside the operating room. So this is to use full monitorization to apply GDP or goal-directed fluid therapy. So for minimally invasive techniques, we put some catheters for continuous analgesic administration in the early postoperative period. So inside the operating room, we use, especially in high-risk cases, hemoadsorption, endoscopic vein harvesting, of course, MiECT, and autotransfusion. So this is the point that we can make a difference. So this is a cabbage, for example, with mid cap. So we always use topical hemostatic agents for the patient lab management protocol. This is very important, especially in minimally invasive surgery, because some points are blind, you cannot see. So for keeping the cross-clamp time lobe is very important. So whenever possible, we use sutureless valves. And of course, the early postoperative period is important. So physiotherapy is much more focused on for the trained before surgery, and neurocognitive follow-up is important for the patient. So anesthesiologists follow them up. And after surgery, the incisions, physiotherapy is going on. So it's now we have about 1,000 patients, a very good follow-up, very good clinical outcomes. So we also have publications to use minimally invasive techniques plus MiECT together, and we have really very, very good results. We can use together, so you can create significant difference in very short, small patient populations. Also, minimally invasive techniques are important to create significant difference inside the operating room for ERAS protocols. So it's a very accelerating process for the recovery of the patient. So usually when you use minimally invasive techniques in the early period, one of the most important critics was to say that the perfusion time was longer because you're unexperienced, you're preparing the patient in a long time, you spend a lot of time. So now we overcome most of those factors. But of course, the easiest way to overcome this longer cardiopulmonary bypass time is to use MiECT maybe to avoid any complications of the cardiopulmonary bypass. So this multidisciplinary approach will be the prominent factor, especially in ERAS or patient lab management protocols that are very much patient-centric, multidisciplinary approaches in the near future. And MiECT and minimally invasive techniques will be the most important point of those programs, I believe. Thank you.
Thank you very much. Sir, what do you think is, when using MiECT during mix, what's the most challenging part of that is?
Of course, the venous return becomes more and more difficult. Normally, it's already difficult, but when you use minimally invasive incision with peripheral cannulation, it's really challenging to control. So we use some vents and something else to overcome.
We have Dr. Beretta from Cardiac Surgery Unit Lansky Cardiovascular Center in Ancona, Italy, giving comments.
Yes. Good afternoon, everyone. Thank you for the possibility to participate to the meeting. Can you hear me? Okay.
We're good. Yes.
Okay. So let me congratulate with Dr. Gunadin for the excellent presentation showing the perfect marriage between MiECT and MiECT. I think that there is no doubt that MiECT must be considered a fundamental component of MiECT. I fully agree with the core message of the talk that the concept of MiECT must be expanded because MiECT doesn't mean only a small cut. We have to go over that, and I'm happy that the Ankara group has implemented a multi-step strategy that goes in this direction. In our institution in Ancona, we have started a multidisciplinary MiECT program in 2016, and we strongly believe that a modern MiECT program has to involve, in a less invasive way, all the components of the intervention. Surgery, using the minimal basic access and the latest technologies and techniques. Perfusion, using MiECT. We have seen that the type 4 modular MiECT can be implemented safely in all types of coronary and valvular surgery. Anesthesia, using fast track or ultra fast track protocols, and mostly post-operative rehabilitation, ERAS protocol. An early and aggressive rehabilitation program started just a few hours after the end of the operations, and allowing a very early patient's family contact as well, may dramatically improve patients' outcome and increase patients and family satisfaction as well. So this is also minimally invasive as much as the length of the cut. So congratulations, Dr. Gutani. This is the way to go to further improve our intervention. I strongly believe in that. Can I ask you a question? Despite the raising evidence supporting MiECT and ERAS protocol, the dissemination of such multidisciplinary MiECT program is still less than expected. Based on your experience, what's the limitation for that, or how can we increase the use of these protocols?
Thank you very much, Dr. Beretta. So I also work in the ERAS Cardiac Society group, and it's a very newly founded society, and ERAS idea in cardiac surgery is, I already said, is very new, with only like three years of kind of history. So as soon as we do more, these procedures is very difficult to apply, you can imagine. So for example, we started working with the anesthesia, with the blocks, and in the early days, they were spending like 1 hour to prepare patients for surgery. So in a busy hospital like ours, so always waiting for 1 hour, 1.5 hours is too long. But now they can do it in 15 minutes. So it's maybe kind of patience. And of course, we need some pioneering clinics to show those kind of results to motivate the others, I believe. And then, so I strongly believe that will be the standard of practice in the near future.
Thank you.
Could I ask maybe a question to the group? Look, at one thing that we struggle with as industry, as we promote MiECT, is that when it comes to to anything around mini bypass and using that same concept, one of the things we really struggle with, especially with the centers that are doing MiECT routinely, is the how do you deal with Breck-Schneider solution, and the fact that you have some practices developing where a massive dose of Breck-Schneider is given, so that there's more time for the actual surgical intervention without having to worry about another dosage happening. My team and I struggle with explaining that I would love for, for maybe just to throw this question out to the group and ask, when you have something that's so contrary to hemodilution, when you have a perfusionist or an anesthesiologist that now has to deal with a massive amount of fluid at one time, what is the best way to manage that? Or, should we as industry be trying to think about, is there another way to remove that fluid aside from using a hemofilter or a hemoconcentrator?
Thank you. So in valves, minimally invasive valve surgery, we routinely use LA venting, and as soon as we start giving Brett Schneider solution, we also take all of them back from the vent. But in mid-cap, it's not possible. So in that case, we are using a diminished dose of Brett Schneider. So we also published the paper on those topic. So we are giving 1 liter for an ischemic time of expectancy of 1 hour. So if we cannot finish in 1 hour, so we give another one liter.
Thank you, sir. That's helpful. I think we want to broaden maybe the use of that information.
I'm not familiar with Brett Schneider solution. I'm assuming it's a crystalloid.
Yeah.
Crystalloid.
Yeah.
Yeah. So we, well, in the U.S., Canada, we're dealing a lot now with modified Del Nido solution. So, and we can give, and you can give modified Del Nido with a microplegia and like a microplegia. So instead of having the regular 3 parts crystalloid to 1 part blood, you can just do just use blood with and still be able to give the same and have the same effect of Del Nido, which is, an hour. You can go up to an hour, and if the cross clamp's going to come off within 30 minutes, you wouldn't redose. But if the cross clamp's going to come off after 30 minutes time, then you would redose after the first hour. So there are ways to do that. It's just a matter of I guess
spreading the word, so to
and,
speak.
Yeah,
right? Yeah.
And
Okay.
I think there's a couple of thousand actual modified Del Nido formulas out there right now. It's crazy. Yeah, so we can.
Sure, absolutely. So it's my great pleasure to introduce polychronous Professor Antonidis, that is associate professor. So just to be clear, right? I think we had stumbled over that before. And he's also from the Aristotle University Hospital here in Thessaloniki. And I've also had the pleasure of knowing him for the better part of 15 years. So it's a real honor to introduce you.
Thank you. Thank you, Mr. Vandrile. I would like to again welcome you all in Thessaloniki. I would like to express my gratitude for following all these MiECT's activities and being every year or every couple of years together with us to see what is the update that we have on minimal invasive corporeal circulation technologies. So I will come back to what is next for minimal invasive extracorporeal circulation and MiECT, and in terms of educational initiatives, MiECT is trying every year to actually promote education on minimal invasive extracorporeal circulation technologies with all the congresses, the meetings, the update meetings, and the symposia that is organizing. If you Google MiECT or MiECTis and try to find what is in there, you will find 189 lectures dispersed according to the Google protocol or according to the search strategy that you will use. So all this material is dispersed on the internet in terms of the time that it was recorded, the circumstance that it was recorded, the place that it was recorded. So we have 189 lectures dispersed on the internet, and we also have the master classes, the academias that Medtronic is actively promoting. We have our program in Thessaloniki. There is also the academia that is starting to get formed. Frank Merkle, together with Adrian Bauer, are working hard to promote education of minimal invasive extracorporeal circulation in perfusion training. But this is actually not enough. Mike continuously tells us that it's about 20% or less the penetration of minimally invasive extracorporeal circulation in everyday routine cardiac practice. And I will challenge him that education is also expensive. In order to have a good education, this is expensive education. So what is another way of promoting education and assisting what we are doing now? Distance learning has further advanced during the last 3 or 4 years, maybe triggered by the pandemic. It started before the pandemic, but actually pandemic gave a strong boost. E-learning, as a general word, integrates many strategies in terms of providing education through online platforms, and then actually assisting and promoting what we're classically doing as a peer-to-peer or as a person-to-person education. There are many platforms that are used in universities for contemporary, for a modern online education. They're called distance learning platforms, distance learning management systems. And actually, we have the chance and we have the opportunity to have Aristotle University. And Aristotle University is actually having all these, the majority of these modern platforms. So we can actually say that we can exploit the infrastructure of Aristotle University of Thessaloniki in order to promote training in minimally invasive extracorporeal circulation. How? How can we do this? All this, there is an uprising tendency. There is an increasing tendency to have courses online that are focused on certain aspects. And actually, this is covered by the general term of MOOCs. MOOCs is massive, actually, and you can question how massive it could be. It's open, but of course, you can have open registration for a certain population that you will actually target for. It's online, but you can also have interaction, and also you can have also there's a cost behind that. And also it's a course that can be accredited by the different societies. So using the modern platforms, we can have online courses that are modern. First of all, they can offer asynchronous training, asynchronous distant remote learning. This is important because you don't have, to cancel all your activities and to go to a meeting. We see that when we are trying to plan a meeting, we have all these cancellations and there is a conflict with your everyday work. So this is asynchronous. You can have the education when you have time. This is important. Second, it can be open to everybody that is registered. So we can offer it to the perfusionists, to members of certain societies. 3, we can actually schedule, we can actually provide education, we can actually try to fit to certain educational goals. 4th, the recording is professional, so it's not just a Zoom recording that we're doing in our everyday computers, but it's professional recording and transmission. Proof of attendance. The platforms can actually provide evidence that you have attended the course for half an hour or for an hour. This can be supplemented with the educational material of MiECT's activities that will be collected and collected to certain files. So as long as you are you have attended the presentation of a classification of MiECT systems, you can have the relative educational material. And then what you have seen, it could be tested with multiple choice question, and the result could be recorded. So as long as you have actually attended the educational material, you have studied the material that is provided, you have done a testing, then you can have a certification that you have properly attended the course and that you have actually gained the educational goals that have been set in the beginning. And then this attendance and this certification can be accredited by the perfusion societies like the European Board of Cardiovascular Perfusion, the American Society, the other European or Australian societies, and you can have let's say, one credit of CME, one CME credit, one credit of continuous medical education. So we tried to create an example of how this could be. I don't know if we have sound. Can we have sound in the video?
Margarita, hijo. Regarding MiECT and taking advantage of the digital library has been created throughout the years from several MiECT's activities, symposia, meetings. We would have courses, online courses of this technology so as to educate and have continuous medical education regarding MiECT. We will discuss about
Hello, I'm Polychronis Antonitsis, an associate professor of cardiac surgery. So this could be an example of one course that could actually provide introduction to minimally invasive extracorporeal circulation in that could last about 30 minutes to 40 to 45 minutes. That it will be easy to attend. Behind the benefits of providing data, followed by the educational material to the attendee, followed by a multiple choice questions, and then followed by the certification that the trainee has attended and has actually understood what what he was seeing. And this is as a proposed syllabus, so we can have an integrated MiECT online training curriculum that could be, let's say, of these 11 parts: introduction, classification of circuits, anticoagulation management, perfusion management in 1 or 2 or 3 sessions, evidence-based medicine, issues on modularity and organ protection, surgical aspects, anesthesiological aspects, minimally invasive cardiac surgery as a separate session, autotransfusion issues. So then this could constitute an integrated course. This could last for 3 or 4 months, accredited by a society and giving you a continuous medical education accreditation. Who will be the educators? Not only Professor Anastasiadis, me, it's all of you. So MiECTs and all the members of MiECTs could actually serve as educators. So we can have professional recording, even remote, expert perfusionists from the major societies, cardiac surgeons and expert cardiac anesthesiologists could be the educators in these activities. So without substituting the dry labs and the peer-to-peer, the teacher with the student interaction, without losing the hands-on training that is very, very important, we can supplement it with an online educator that will help the attendee study properly, understand the principles, have an online library with the major presentations, so that it will be easy to come back and back again to revise and to consolidate the knowledge. And this actually could represent a more effective way of promoting education in minimally invasive extracorporeal circulation, offer it to a broader audience, and then have the proper on-site training. Thank you very much, and we are open to any comments or questions from the audience.
Thank you, sir. Hey, I think we had, did we have an online commentation coming from Professor Punjabi? So
Yeah.
Perhaps we could already go ahead and, hey, thank you, Professor. Welcome. And obviously, Professor Punjabi is the chief at Hammersmith in London in the UK.
Thank you. Thank you. First of all, I'm terribly sorry for a few minutes of loss of communication, but I have been hearing continuously. So let me start first by congratulating every one of you since the sort of start of the MiECT. I have been heavily involved for quite a few years, but to see it grow to the current extent when Kyriakos introduced the session by giving us what the statistics are, they are very impressive. Oh my God. We are actually looking at the 17-year to be a success. 17-year wait doesn't necessarily always be a success. So thank you very much. I think that's really commendable, and my congratulations to everybody to reach this point and have this current MiECT. And I look forward to the next one. 10th one should be all in person. I think we should all need to be together. I just wanted to quickly also comment on a couple of things, but just Polychronis just introduced the concept of course, and I think it's more than one. The purpose is by educating, you take the fear away of implementing MiECT. I think the current adoption rate partly is also because people either don't know, or they are afraid, or they are too reluctant, or they are too hesitant. And this course is a way to say, actually it's quite easy. This is the definition. This is the literature. These are the anticoagulation strategies. You don't have to change much, but this is what standardization provides. And I think, in my opinion, that serves more than one purpose of simply certifying. Yes, of course, that is the main purpose, but I think the background purpose is more about getting everyone to believe and start believing. And I, for very one, would like to see this more in my center. And we've had a couple of changes with new perfusionists and new surgeons, and we've got 3 new surgeons. None of them have ever experienced or done any MiECT, but we've discussed, and they are open to exploration. So I think that's one. So secondly, from the sort of association and collaboration between perfusion and MiECT, I think it's been a success story. It's only growing more, and I'm seeing the results more. I'm seeing the more input, and I'm seeing the response to that. And in the last editorial board meeting, we were looking at a couple of most prominent papers, and there were a couple from MiECT associated with MiECT. And I think that is such a popularity-wise, a important concept to take away, that MiECT is growing. And I'm on a meeting. So sorry. And frankly, we are now at a point where we will be able to, I think, encourage participation and expand the numbers. What Kyriakos told us this morning is already a very this is just at the start of the session, is a very, very encouraging graph, if you want to call it, and prospects. So thank you very much for being making me part. And we at Perfusion are enjoyed. I know all my associate editors are very pleased to be associated with MiECT. Thanks.
Thank you, Professor.
Small comment.
Yeah, it's absolutely. You're asking me.
Thank you.
Thank you, Prakash. What I want to add to what Polychronis has implied here is that we have a huge digital library that is inviolable.
Oh, yes.
Just don't forget that there are about 200 lectures there from key opinion leaders. All of them are accumulated in this society, and want to take advantage of this. And since we have discussed with John and Mike, as I have said last year, what we did is we categorized all these, and we found that we have roughly about 11 categories. So as soon as someone is approaching these MOOCs, this online course, then at the end, before having the exam, he can review the relevant digital media about the course that he has been taught, and after that give the exam. So it's a kind of integrated lecturing, because it gets a message from the update that will be fresh. It can review the library of MiECT. It can have the exam, and then at the end having the CME credits. So for me, it's a kind of taking advantage of all of you that have contributed all these years to this technology. And it's a handy tool for the societies, even for a journal that can be a live journal here. Prakash, this is my comment.
Yeah, no, I think I would be very much in support of that, and we should explore that so that we can have a sort of link as part of the, where we have the official collaboration. We can say, for educational material, kindly click on this link. Yeah, I would be very supportive. Thank you.
I think one of the a comment I would like to make is, it's still very much a team, a team learning experience, and I think if we can gear this not just towards perfusionists but also towards anesthesia, cardiac surgeons, and have it on everybody's radar, right? And I think the one thing, it's okay for me as a perfusionist to go out and to learn this technology or to learn about this technology, but if nobody else in my team, if my cardiac surgeon is not doing that, then I don't know how far we're gonna go with this as far as being able to truly implement a new technology. I don't know if you want to comment on that. Is that the evolution of this? I mean, that's kind of what I think.
May I bring someone into this
Absolutely.
discussion? It's Marwa Eid, who is representing the young cardiac surgeons from MiECT. So she can comment on this initiative, because I think that would be interesting for young guys, young surgeons that want to be involved in this technology. So Marwa, what's your opinion on this?
Well, I'm just gonna give a quick comment about that. I totally agree about the fact that a young surgeon coming into a team, even if they have very nice visions about what should be done regarding minimally invasive extracorporeal circulation, alone they won't be able to do anything. So I think that knowledge is key, and I'm going to talk about it a little bit in my presentation. Knowledge is key, of course, and the fact that there is a library available with courses would be very much needed and very interesting. But I think also that the collaboration with the other teams is essential, because somebody on their own, they can't do anything. And basically, we need the perfusionist, we need the anesthesiologist, and also we need the surgeon. So I won't comment more, and I think my talk will bring you some of my ideas also.
Thank you. Very nice. I think we can move on. So our next speaker is Dr. Mark Bennett. He's a consultant anesthesiologist at the Swansea Bay University Health Board, and he's on the steering committee of MiECT. I've met Mark in this forum many years. I'm not going to say how long, and he's been a very valued member of our steering committee and of MiECT. So Mark's going to talk about expanding MiECT in anesthesiological practice.
Thank you very much, Cyril, and thank you to the organizers of the meeting for inviting me to address how we might expand MiECT in anesthesiological practice. And I'd like to add to that title, how to expand and infuse anesthesiologists in mini bypass. Many talks along these lines in the past have addressed what you've just referred to, which is the involvement of anesthesiology in teamwork and in fully understanding the systems so that they can be part of not only the team, but the safety of the environment in which they're working. I want to take that a little bit further and question how the anesthesiologist actually might step forward and become leaders in the development of MiECT in their centers. You've seen this graph from Professor Anastasias and from Ashraf, and we know that this is what we now understand might take 17 years to go from the early innovators through the early adopters to involve a larger number of centers as the early majority. And I want to look at this graph in relation to how we take the anesthesiologists to become the early majority, not just the centers. The MiECT innovators were clearly inspired by the potential philosophy of the technique, the science and the technology. Although at 25 years ago, when there was no published literature on this, this is what drove them to advance these techniques. The early adopters, both surgeons and anesthesiologists, together with their perfusion teams, will have been further inspired with the early publication across a huge range of physiological improvement that could be seen in the patients. But how to move into the early majority? Well, I will remind you of the Burkhardt-Harris change equation. In that dissatisfaction with the status quo, a clear vision provided, as Polychronos has just indicated, through good education, and a clear understanding of how you take the first steps, all have to add up or multiply together to overcome resistance to change. And resistance to change is all about what we're talking about today. I'm going to go straight to the vision part of that. And I think the key to this, as involvement of the anesthesiologist, is to formulate a question that they fully buy into and understand. The evidence has to be clear. It has to be able to be critically appraised before they will begin to incorporate that evidence into their practice or encourage incorporation into the center's practice. So we need to formulate a clear question, such as in adult patients undergoing on-pump cardiac surgery, does MiECT or conventional bypass provide? And then you have to fill in the gap. And you have to fill in the gap with things that are important to the hospital. Well, money talks, and the hospital will want to know that this doesn't cost more money than the previous technology, but more importantly, that the outcomes result in less expensive, deleterious outcomes to patients. The next gap could be filled by what's important to patients, and you may know that there is very little in the literature that has amalgamated the views of patients about what they think is important in cardiac surgery. And then together, the surgeons and anesthesiologists will have that view about what the important questions are. But it's important that we're not paternalistic in our views of what is important. Some suggestions about what is important were raised by the ERAS Cardiac Society together with the Perioperative Quality Initiative in the United States, but they came up with a, you could argue, paternalistic list of aims that have been really the focus of cardiac surgery and perfusion for at least the last decade, albeit opioid analgesic reduction was a little bit late to the party. So I'm not going to concentrate on these outcomes, but rather point to you to the sentence in their conclusion, because they said one of the biggest obstacles to providing these benefits is a general lack of clinician education and experience, patient staffing ratios, teamwork, pathways, and protocols. And here I will congratulate this society and the authors that have pointed out that MiECT is a strategy, and it has concentrated not just on the technology, as might have been expected in this paper, but on the whole ethos of developing this technique. But I won't go any further with that. In the UK, the NHR, together with what's called the James Lind Alliance, aims to work with patients, clinicians, and their carers to set research priorities across a wide range of surgery. And in 2019, they published these top 10 priorities in cardiac surgery. Now, of these, 4 have been the focus of attention within this society. And it is not surprising then that the evidence that has already been presented in this meeting, that there is strong recommendation in the 2019 EACS, EACTA, and perfusion guidelines for the use of MiECT circuits. Now, most of these initiatives, as they take them forward to further the evidence, are led by surgeons. But it's the ones at the top that I'm going to talk about for the next couple of minutes, because these are being led by anesthesiologists and intensivists and form 4 out of 10 cardiac surgical priorities. The first of these has already been alluded to by Ashraf with his talk on elderly patients, but I just want to remind you that frailty is not always elderly, and there is something quite different about being frail. This data from Ontario in Canada by Daniel McIsaac demonstrates that over half of patients, at least scored by the Patient Frailty Index, reach a score of greater than 0.21 and are therefore considered to be frail, undergoing general surgical procedures. And I will come back to this, but what the graph also shows is the inexorable fall in the numbers of days at home within the first 30 days after surgery as patients become increasingly frail. And days at home at 30 days is an amalgamation of many factors that keep patients in hospital. Lee and his colleagues put this very plainly, that frail patients have 2 times the risk of operative mortality and 3 times the risk of midterm mortality, along with increases in all other ranges of morbidity. So rather than talk about the dissatisfaction with the current system, maybe we could change that to the challenge of incorporating change. This is what frailty is composed of. It does include age, and it does contain multimorbidity, but it also contains lifestyle, social environments, and cognitive factors. And all of these together form what's called frailty. And essentially what frailty is, as it says, a decrease in the reserves to counter physiological stresses. And there is no doubt that going on bypass is a major physiological stressor. So the challenge to this society, to researchers and innovators in the field, if we're going to engage the majority of anesthesiologists, is to look at how we provide evidence with MiECT of improvements to quality of life, improvements in frail patients, and those patients who have chronic conditions. I'm pleased to see that ERAS Cardiac are going to produce another document, because you will remember that there was a huge gap in the middle of the ERAS recommendations with almost nothing that related to bypass at all, and we look forward to the forthcoming publication. So finally, if you look at what we know about MiECT and frailty as opposed to elderly, there is almost nothing that relates to the duration of bypass or the type of bypass to improved outcomes in frail patients. What if we surround patients who are frail across this wide range of the composite that makes up frailty with all of what we know are the beneficial elements of MiECT, and study what impact having MiECT compared to conventional bypass has on those? I think if we were to address that question, we would bring a lot of anesthesiologists' interest to the fore. Potential outcome measures are, as reported by McIsaac, days at home in the first 30 days or days at home in the first year, because all of these combine morbidity, mortality, delayed extubation, the early quality of recovery, delayed discharge, non-home discharge, and readmission. And how many patients would we have to study? Well, if frail patients have a days alive at home in the first 30 days of 16 days, whereas non-frail patients have a days alive at home in the first 30 days of 21. And we said we would aim to put our frail patients somewhere in the middle. That's an increase in days at home of 20%. A very, very quick sample calculation suggests that we would need to study 254 frail patients. What is important about that number is, I think, how relevant frailty is, that it is an absolute key target for grant funding at this moment. And I think that if we did so, we would enthuse and engage anesthesiologists about the benefits of MiECT. Thank you very much.
Thank you very much, Mark. Now, former president of MiECT, I'd like to introduce John Merkin, professor of anesthesiology from London Health Science Centre in London, Ontario, Canada, to give his comments, please.
Yeah. Well, thanks very much, Mark. I think you've addressed a number of issues that have been progressively, I guess, identified over the last decade as more and more of these publications are being presented. And it's the, I think, appreciation of the various minimizations of some of the stresses that these patients undergo is seen in improved outcomes. But I think the premise, how do we engage more anesthesiologists, is a little bit off the mark. Because I would say that most of the time anesthesiologists are very flexible, and we have, very successfully incorporated ISMICS type procedures, beating heart surgeries, off pump surgeries. And at least with our colleagues, we've been very willing to get engaged in MiECT programs. But as we've heard repeatedly, it's a team approach. And in the absence of, a significant drive from either surgeons or perfusionists, it's difficult, speaking very personally, for anesthesia alone to initiate a program such as this. And I think, as we're going to be talking about very shortly, some of the most important aspects are the publications that are starting to accrue. And particularly, as we'll be discussing later on in this session, the results of the randomized trial, the COMICS trial. I think when that comes out, that will have a significant impact in getting everyone's attention, that this is not only a viable modality, but has very direct impacts, positive impacts on patient outcomes. And I think this will not only engage anesthesiologists, but also, as we've heard, perfusion, surgery, and will help with the overall development of this as a much more common modality. So I think really more publications is the primary driver of all of this. Evidence-based medicine, I think, is what's going to determine the more successful incorporation of MiECT procedures.
I totally agree with you that anesthesiologists will, if the program is developing in their center, enjoy the new challenge, the being part of the team. I rather tried to put it that perhaps they could become the leaders, where at their regular monthly morbidity and mortality meeting, where we're discussing once again a frail patient who has been on the unit for 30 days before finally succumbing to some inexorable decline, might actually have had a different surgery. And from that perspective of having looked after that patient for 30 days before they finally demise, they could say, is there something we could have done differently to give this patient a very different outcome and force the position of the surgeons and perfusionists within that department to engage in something that would be more physiological for that patient from the outset. I just wanted to see if I could be slightly controversial and push the anesthesiologists to the forefront of this, rather than have them, as you say, willingly engaging in the rear guard.
Yeah. Well, I think we need to push from every direction, and I think that's really the multidisciplinary focus of this very society, to try to generally raise the awareness. And as I say, evidence-based medicine, I think, is going to ultimately determine the success of these types of initiatives.
Well, thank you. Thank you both. I'd like to move on to the next topic. And Dr. Ed from the University Hospital in Angers is going to follow up the question and the comment that had happened before, introducing MiECT in young cardiac surgeons.
Thank you very much. So I would like to thank the organizers first for inviting me today to this meeting, and I'm going to start my presentation now. Can you maybe put it up, please? Thank you so much. So introducing MiECT in young cardiac surgeons, I changed a little bit the title with adding why is it time and how should we do it? For starters, I would like to take a step back on the state of cardiac surgery training in Europe. Achieving training in cardiac surgery in Europe is very different. There is a lack of uniformity that impairs the surgeon's mobility, the exchange of knowledge that it's possible, the exchange of skills, and there is no transparency regarding the different centers. Therefore, there is also no external evaluation of the centers regarding their ability to train properly their residents. When we look at the cardiopulmonary bypass training in France in particular, there are two non-compulsory university diplomas that exist. They both focus on physiology, materials, and incidence. Cardiopulmonary bypass is presented as a tool, and the focus is given on managing the complications instead of avoiding their occurrence through an optimized CPB. So to summarize the state of training, there is no consensus that exists on how to train CPB among young surgeons, and the training focuses on the outcomes, but not on the preventive aspects of CPB through an optimized procedure. So therefore, we can ask the question, is this enough? Shouldn't it be time to introduce the miniaturized extracorporeal circulation principles among young surgeons? I would consider the answer to be yes. And looking back at the first position paper of the society, it is stated that the penetration of MiECT technology into clinical practice is extremely low, as you said it before. And one of the reasons is being exposed that there is an inability to clearly predict which aspects of this technology are really beneficial for the patient. And this is one of the arguments of the teams to not go for MiECT. The paper also reminds us, and we're going to talk about it afterwards, that it is very important to have a team effort in order to introduce such technology into a surgical OR. Despite these different elements, considered by some as barrier to start a miniaturized extracorporeal circulation program, studies shows the advantages, as you all know, of MiECT compared to conventional. This first meta-analysis that is a little bit old, but has the beneficial to group 134 randomized controlled trials that includes more than 22,000 patients in total, had compared conventional to MiECT and to off-pump in CABG. The key findings of these comparisons shows that outcomes were similar regarding all-cause mortality, postoperative myocardial infarction, cerebral stroke, postoperative AF, renal dysfunction, and this was when comparing to MiECT to off-pump, so no differences between the two. But on the other hand, when you look at conventional, they had the worst outcomes when we compare it to MiECT or to off-pump for CABG. The main conclusion of this article is that MiECT could be an attractive compromise between off-pump and conventional. That was said before, but also that could emphasize the beneficials of MiECT for the patient's outcomes. A more recent meta-analysis compared MiECT to conventional for CABG and non-CABG procedures. The total number of patients is lower, and beforehand, the patient did not present any significant differences between the two groups. This study did not conclude on any difference between MiECT and conventional when we look at the specific different postoperative outcomes that were presented in the previous meta-analysis. And this might be a number effect because this regroups less randomized controlled trials, only 42 studies in this meta-analysis. But this also regroups CABG and non-CABG procedures. But when we look at the authors' composite outcomes, regrouping mortality, stroke, and renal impairment afterwards, there was a significant difference between MiECT and conventional patients' outcome. Also, there was a significant difference when we looked at the length of stay at the hospital and the transfusion rate that we know that impairs the patient's survival. So miniaturized extracorporeal circulation has a positive impact on patients' outcomes, as confirmed by literature. But what do we know about learning to implement MiECT in surgical teams? That paper, I found it very interesting because it talks about learning curves, and it's not something that is very often presented in surgery. From the start of the program in a monocentric study, so this is your study from Thessaloniki, there was a total of 150 patients included, and 75 patients composed the MiECT group, and 75 patients composed the conventional group. Patients were treated for elective CABG by the same surgical team, and the primary endpoint of the study was the learning curve. Interestingly, we can see that as soon as the 50th patients, there were benefits from MiECT versus conventional. This started and persisted up until the end of the study. There were no major adverse effects reported when we looked at the different groups. So according to this paper, we can conclude that the learning curve of MiECT is short and the benefits are real for patients during long-term follow-ups. So having all these elements in mind, the final question would be how to effectively introduce MiECT among young cardiac surgeons. EACT's Residence Committee published a paper last year on the principles of cardiothoracic surgery training, including the teaching of cardiopulmonary bypass as fully part of the residence curriculum. Standardization of cardiothoracic surgery training in Europe would allow to ease trainees' exchanges between the center and therefore open the possibility for young surgeons to learn MiECT from centers that are fully convinced of its use for the patients. Teaching MiECT to young surgeons should be focused on acquiring the knowledge, be performant in the OR and acquiring the surgical skills in order to set up a CPB, and acquiring also soft skills because, as you all know, communication, collaboration, and leaderships are key in the OR in order to make the CBP as efficient as possible for the patient. But I would like to emphasize here that the main difficulty would be for a young cardiac surgeon to implement new ways of practicing surgery among his team. Therefore, I would add that the importance of a teamwork is necessary in order to bring shifts in the surgical habits. One young cardiac surgeon can't do it alone. As to ease the transition, the knowledge on MiECT principles are essential because, as you know, there are different types of MiECT, and maybe one of the possibilities could be to progressively introduce the different components and different aspects in order to arrive to the type for MiECT in the end. And the optimized extracorporeal circulation can be an alternative to ease this transition from conventional to MiECT. In the end, the aim would be always to improve patients' outcome. So my take-home message for you would be that MiECT is safe and feasible, but I guess you're all convinced of that. It improves patients' outcomes in an effective way. The learning curve is short, but the main thing to keep in mind is that it's a team effort. So the collaboration between surgeons, perfusionists, anesthesiologists, intensivists is absolutely necessary in the interest of the patient. Education of residents is key. Time should be dedicated to acquire knowledge, surgical skills, and soft skills. It has to be kept in mind that the transition can be eased through a progressive acquisition of the different aspects of MiECT. Why not via an optimized extracorporeal circulation? And I would like to leave you with this quote that I think summarizes really well the importance of teaching the youth the future. Thank you so much.
Well, thank you, Dr. Id. And I think Professor Balferton is waiting to be able to provide some additional commentary.
Hello. Thank you, Mike, for giving me the opportunity to comment the purpose of Dr. Head. And as you know, she talked on the behalf of the resident committee of resident of the EACS Society. So I would like to come back on these purpose and to emphasize some points. Number one, it's very interesting to consider that the learning curve for MiECT is shorter than for MIECT, which had a very easy penetration in young surgeons. But anyway, we know from the ERAS guidelines that we recently published with a group of French surgeons and French anesthetists that MIECT might be questionable in terms of benefit, but if there are enough benefit for that MIECT, it's probably beneficial through the use of MiECT, which is associated to the practice of MIECT. Number two, Marwa emphasized also the low penetration rate of MiECT and OPEC in our current practice, and especially for young surgeons. And this is mainly due to the fact that the training process are not always focused on the preventive aspect of CPB management. And this is something that we have to probably take into consideration and to correct. Number three, a lot of young surgeons are very interested in the environmental impact of cardiovascular healthcare. They are interested in the footprint of carbon footprint that needs, first of all, to be concentrated. I mean, their mind should be concentrated to the physiologic aspect of the CPB management. And number four, I would like to say that although Marwa showed some controversial results coming from meta-analysis, one of the meta-analysis showed that MiECT is almost as efficient as off-pump surgery, but do not forget that this MiECT could be applied to open heart surgery as well, and not off-pump surgery, of course. So the other publication, the other meta-analysis seem to show no difference in terms of mortality, probably due to the more limited number of patients included in that study. But anyway, if you look on the transfusion aspect of that meta-analysis, you can see that it may be further translated in lower mortality at long term, because we know that transfusion is one part and actor of the deadly triad of mortality in cardiac surgery. What I would like to say to conclude for young surgeons, MiECT should answer to the modern incentives of modern cardiology, and as a mentor, we have to convince the youth surgeon to go in that direction. For instance, in patients coming in our center with a dual antiplatelet therapy, and that represent in our center more than 50% of the patients, then we have to use a reduced goal-directed anticoagulation, and without the capacity to manage adequately MiECT, it's impossible to propose to the patient. Second point, for the cardiac surgery for very high-risk patients like endocarditis, for instance, the possibility to manage as well as we can the systemic inflammatory response syndrome is very important. And this is what are currently thinking cardiologists about the future of our specialty, that we will keep for the future what they call the AV cardiac surgery. So the young surgeon has to be aware about the fact that they will practice their specialty in very much more difficult patients than we had in the past when we started our specialty. And I would like also to thank you, all of you, for organizing this meeting and giving me the opportunity to comment this proposal. Thank you very much.
Well, thank you, Professor.
Thank you. Is Philip Summer still online? Wonder if he would, Philip, if you'd be able to give a comment as the chairman of the European Board of Cardiovascular Perfusion. Philip, are you online?
There is a problem with his connection, they said.
Problem with his connection. Okay, so let's move on. Okay, our last speaker in this session of current status is Dr. Florhanger. He's cardiac surgeon at the Department of Cardiac Surgery in the University Hospital of Rosenberg. And he's going to talk on long-term results from MiECT use.
First of all, thank you to get this invitation to talk about long-term outcome after minimized bypass. When I read the topic, I was a little bit wondering if I hadn't noticed some data about this, because usual long-term data about CABG, I will talk mainly about CABG, are usually dealing with graft patency or CABG versus PCI. And this will be one of 3 points I will talk about in this talk. If there are some, thank you. If there are some long-term outcome data of using a mini bypass. As I said, is there an evidence out there of long-term outcome after MiECT use? If not, are there some factors which impact long-term outcome? And based on these factors, I will show you some institutional experience. First of all, I went into literature and I found this study. This is a meta-analysis, which you have seen before, from 21. And they took 40 studies, only RCT studies, and compared conventional versus mini bypass, more than 5,000 patients, or almost 5,000 patients, CABG and non-CABG procedures, the endpoints, mortality, stroke, AMI, blood loss, renal failure, in a composite. And what they found was a clear benefit of a composite of mortality, renal failure, and AMI, and also shorter hospital stay after using a mini bypass. But all these studies which were analyzed did have a long follow-up. So they also concluded, if you look at the red arrow, there needs to be a long-term outcome, because there are no long-term outcome data available. But finally, I found one from Switzerland, 6 years old, published in 2017, and this was a single center analysis with more than 2,000 patients, CABG only, and they looked on mortality and did a follow-up up to 6 years. The mean was 3.6. And they compared the life expectancy of these patients after CABG with MiECT compared to a gender and age-related general population without surgery. And what they found was pretty good. They had a 30-day mortality of 0.8%, which is really excellent, and then 6-year mortality of 9.1. And if you look on the right side, the red curve is the general population, the black curve is the surgery population, and there is no effect of surgery. So they achieved that patients with surgery have no worse outcome compared to surgery patients, and I think that's the best result you can get. But that's it for long-term outcome data. Are there other factors for which support long-term outcome, better long-term outcome? And I found 2 studies from Thessaloniki. One study analyzed the quality of life. For the assessment of quality of life, they used the SF-36 form questionnaire from the RAND Corporation. It's an 8-point questionnaire looking on several points, quality of life, with vitality, pain, emotional status, physical status, and they extracted a summary score, a physical summary score and a mental summary score, and they compared CABG patients with conventional and mini bypass preoperatively after 4 weeks and after 12 weeks. And mini bypass CABG patients performed in both summary scores better than patients with conventional bypass, physical and mental. And the other study looks at the achievement of fast track recovery, also comparison of CABG patients, conventional versus mini bypass. And they could see that after mini bypass, the fast track recovery could achieved in much more patients reflected by ventilation time, inotropic support, ICU stay. And these factors are not really long-term data, but these data may support better long-term outcome. Which factors are, from my point of view, critical for better long-term outcome? And I think everybody knows that. That's first of all the renal function. In this review from Nature Reviews, there's the acute kidney injury, cardiac surgery associated, and there are many ways, many mechanisms to lead to acute kidney injury. There's inflammation, there's hemolysis, there's ischemia reperfusion injury. And I think the best way to avoid ischemia reperfusion injury is to avoid ischemia. And that brings me to the main point from my view is low flow and low pressure and hemodilution. And if you have this, you have a vasoconstriction in the kidney, then you have the acute kidney injury. And this, if you have the acute kidney injury, you have a high risk for develop chronic kidney disease and end-stage renal disease with impaired motility, impaired long-term outcome, and a higher risk for cardiovascular events. And the second point is no, it doesn't work. Well, in conclusion of this slide, if you don't have an acute kidney injury, you have a better risk for better survival and better long-term outcome. And the second factor is the transfusion. In this recent review, they analyzed 180,000 patients after cardiac surgery, mainly CABG patients, but also valve and combi procedures. And what you see here is more than 4 of 10 patients receive red blood cell transfusion. And if you look in long-term survival, even after 15 years, the survival is much worse if you're having received red blood cells during surgery. And based on these two factors, transfusion and renal function, we looked on can you please the next slide? Based on these two factors, we analyzed our own data. We just looked on perfusion data. Thank you. We compared conventional versus mini bypass, and the readout was only perfusion monitoring and corresponding with body mass index categories. And you look on the left side, you see the dots are conventional and the triangles are mini bypass. And as soon as you put the patient on the bypass, you lose serum hemoglobin. So you lose almost 5 hemoglobin points on conventional and not even 3 after when you put the patient on the minimized bypass. And if you look on the right side, even if you have lower pump flow, 4.1 versus 4.9 liters per minute, you have even more higher blood pressure levels in minimized bypass. So you have more sufficient perfusion if you use a minimized bypass. And that are nice perfusion data, but does that have a clinical relevance? Yes, it has. The same cohort, we did a mortality analysis and looked for renal failure and thromboembolic events, and we did a propensity score matching, and with a clearly lower mortality and lower rate of renal failure requiring hemodialysis. And with the propensity score matching, we did a regression analysis, and this revealed conventional bypass is a risk factor for mortality, renal failure, and AMI. And this risk factor is comparable to pre-op ventilation and cardiogenic shock. In conclusion, to be honest, long-term outcome data after MiECT use, the evidence is thin, but the factors who may affect long-term outcome, there's a clear evidence for significant benefit after with using a minimized bypass. And to be honest, at least in CABG, there's no reason not to use a mini bypass. And for getting a modern concept, a modern strategy for cardiac surgery getting established, using a mini bypass is a crucial point. Thank you.
Thank you very much. Now I'd like to invite a very important member of our steering committee, Dr. Ashraf El-Asawi, who's cardiac surgeon at the Department of Thoracic and Cardiovascular Surgery in Göttingen, to make some comments.
Yeah, thank you for a very interesting presentation. I have 2 to 3 questions. Well, I'll state them one after the other to give you more enough chance to reflect on each of them. You just told us there is no reason why not to use a MiECT in CABG patients, and obviously you're one of the most experienced with the longest experienced centers in Europe, maybe even worldwide, with implementing MiECT in CABG. So which patient still gets CABG on a conventional system in your center? And why does he get that?
Okay, you got me there. Sorry. You got me there. Some reasons not to do. I talked about experienced surgeon. To be honest, we do not resident training on mini bypass. We do also not bypass surgery between at night time. I told that in Athens a few years ago and was blamed by Thierry Carrel by that. But to be honest, we do, as I said, not resident training on mini bypass. They got conventional. And also emergency surgery in the nighttime. If there are some reasons why it could be difficult, we don't do mini-bypass. We do conventional.
And when do you do op-cap surgery? or where do you see the indication for OPCAP surgery in your center?
Well, we participated in the OPCAP study and we stopped OPCAP almost completely because we don't see a benefit of OPCAP. There are some, if you have calcification on the aorta, some just Lima LAD, it's really rare we do, but we stopped OPCAP almost completely because we don't see a benefit.
Okay, and one final question. Did I understand it right? You never attempted in your center to go into aortic valve surgery or anything beyond CABG?
Yes, you have understood this right, yes.
Okay.
Because we stick to type 2 because if you implement, even if you don't use it, an additional component, you get nearer to conventional. And we stick to the ECMO fashioned system type 2.
Okay.
As I said initially, it's philosophy.
Thank you very much for the honest answers.
Thank you. Well, that concludes this session. And we will quickly go to our next session on research and development of MiECT. And I'll hand this over to our moderators, Polychronis and Serdar.
Okay, so we pass immediately to the next session, and this is I would say probably the most important session of the MiECT update meeting. Is the time that we liaise clinical with the industry, and it's my honor and pleasure to introduce Mr. Van Driel, who is a great and continuous supporter of minimally invasive corporeal technologies, and he is here with us. He's the business director of the extracorporeal therapies sector of Medtronic, and please. You have the podium, and
thank you, sir. Can someone pass me the?
Yes, of course.
There you go.
Yes, of course.
Wow. Hand
Thank you again.
Thanks,
Thank you again for coming to Thessaloniki, and
it's always my pleasure. Yeah. This is a very important meeting to us as well as to me personally. So thank you for the invitation. Let's go ahead and start the presentation. I'm going to try to recover a little bit of time here for the rest of the sessions. But my name is Mike Van Driel. I'm the director of our perfusion business here in the region, and we do keep statistics about how many of the perfusion components, or like cannula, blood management, including anticoagulation, ECMO, ECLS, as well as mini bypass or regular conventional bypass. And we did a survey of about the 1.3 million cases that are done internationally, throughout the entire world. There are 1.2 million of those 1.3 million total on-pump cases actually involve something from Medtronic. So we're proud of that footprint, and it also comes with a pretty big obligation to continue research and development. Even though our relationship with Spectrum Medical has ended. We still remain convinced that technology represents the best path forward. When you talk about the level of sophistication of the software, the ability to use it for any type of MiECT cases, from class 1 to class 4, this is definitely the best system to be able to use, and that's on the market. There's a new level sensor coming out that can be tied to another roller pump or to a automated sort of a volume addition system. That's unique to what Spectrum Medical is doing. So, there's a lot of great stuff that's still out there, and you can obviously use that with our centrifugal pump. There are a few other pieces of technology that are out there. We're in year 5 of the introduction of our new autolog system, the cell saver, that you do need to be able to implement adequate sequestration and separation of blood and aspirated blood from the field. But one other thing that is important is that actually, I think I was missing a slide there, or it might be in the wrong order. Before I jump into the material piece of this, oops, let me go back. One thing I did want to mention too is that there was a slide here that was showing our fusion oxygenator, which we launched in 2012. The Medtronic has invested about $5 million in the ability to make our own fiber. And why we believe that's important is that, certainly during the earthquake that hit our region in 2012, in combination with the recent epidemic that we had with COVID, we've discovered that we've realized yet again that we really need to be more self-sufficient. And we introduced this new Medtronic fiber for the oxygenators on our Affinity NT system that we launched in 2019, right before the epidemic, with great success. We've run about 500,000 cases now with that oxygenator, and we're getting ready to introduce that fiber onto our oxygenator as well. And why that's why that's specifically more important is because we believe that fiber is more consistent. It's easier for us to manufacture the bundles because it is more consistent, and we're expecting to see a greater continuity on our Fusion oxygenator with that fiber, and we'll be calling that Fusion Plus or something like that. But it's going to be a big deal. It may not look outwards that doing that kind of innovation is a big deal. However, when you consider the amount of technology development that goes into making oxygenator fibers, it's not an easy task. And more importantly, we've got about 2.4 square meters of fiber just in Fusion. So when you look at the 375,000 oxygenators that we make a year, you're talking about thousands and thousands and thousands of kilometers of fiber that we have to make every 2 or 3 months just to be able to do that. What I did want to say is that there are two things that you've all heard me continue to pound this discussion, in with the surgical community. We're not out of that COVID material problem yet, right? We're seeing that you guys are all impacted as physicians when it comes to materials, but more importantly, when it comes to being able to have an adequate level of service within the hospital, within the ICU, with nurses that are in the recovery rooms, in the recovery areas. Mr. Bennett and I were just talking about that. Even the COVID cases in the UK, they're still not back to where they should be. And we've seen the same. We're at about, for the region I'm responsible for, we're at about 90% of where we were before COVID in terms of on-pump cases. That same thing is hitting us. It's we're seeing labor shortages that are continuously being difficult for us to manage. We have labor shortages in Kerkrade where we make our custom sets, and we're struggling to keep up. We have labor shortages in the facility at DLP in Michigan, where we manufacture our cannula. But even more importantly, the material shortages that we're seeing, where the amount of PVC or the amount of silicone or the amount of stainless steel that's out there for us to be able to use for medical device applications, you guys are seeing it in the cannula. You guys are seeing it in the lack of availability, especially with silicone, with some of our fellow manufacturers and their ability to be able to manufacture tubing sets. We're not out of the woods yet. And it'll probably take us about another year as we and all the other manufacturers continue to work with the raw material suppliers to try and resolve this issue. But we're going to have to continue to ask for your patience and continue to ask you guys to focus on caseloads, not inventory, because we're not in a position to be able to get everybody healthy on the shelves with the cannula that you really truly need. And certainly with some of the other products that we're having trouble with, including cell saver kits that you truly really need in your own inventory. One last point, with MDR, the MDR regulations are, yes, the medical device directive has been postponed in terms of its implementation. However, though the implementation only means that they're giving us more time to submit our files, but we actually, as manufacturers, we have to submit a written notification that we intend to submit, and we have to show them where we are in the process. A manufacturer can't just say, well, 2 months or 2 years that's later, it's pushed out to 2027 or 2028. What that means is that we have to show evidence to our regulatory bodies, to our notified bodies, that we are actually doing MDR. And the MDR regulations, as some of you have heard me present on before, the big difference with the MDR regulations is that you have to provide clinical evidence now. When you put a product on the market, it's not just putting a product on the market, it's that you actually have to provide clinical evidence for those devices that they're being used just as they are intended. The classification of cannula, for instance, has been changed to the equivalent level of a classification of heart valves. So we've already set up registries where we have to actually do do post-market assessment and post-market. We have to collect post-market data on patient outcomes with all of our valves, with all of our rings, but also in cannula. It's the same class. Okay, so imagine that we've got 800 different cannula across 40 different families within our catalog. That means we have to actually have a clinical database for each one of those families. It's a huge undertaking, and that's also impacting and having an issue, certainly having an impact on our ability to also keep these cannula on the market. Yes, the deadline has been moved out, but it's still all of our responsibility as all manufacturers, and I'm taking the onus of being able to speak for all of us. We still are under the gun and under a lot of pressure to try and meet the signaling regulations where we have to tell them where we are in the process. If you do not, as a manufacturer, tell your notified body, in our case TÜV, where you are with that process, you do not automatically get a CE mark. So kind of keep in mind that there are companies out there that are not doing the CE mark. By extending this under MDR, by extending this deadline, it does not mean those products stay in the market automatically. All right. It's a very important point because it does affect the ability for you guys to do clinical cases. And of course, we talked a little bit about education. We talked about training young surgeons, young perfusionists, and young anesthesiologists. And our commitment to education, we treat this as almost like a product line, to be honest. Our commitment to education, and our theory about teaching, leading to adoption, and let the products follow, we continue to do that. We're holding our Options and Outcomes Congress in about 4 weeks in Munich. That's an extension of what we call our academia, or what used to be known as academia, that's now known as MiECT. That's a part of our education program, just like the Thessaloniki courses, just like the some of the the Bern courses, and like some of the other on request courses that we have throughout the rest of Europe. And with that, I'd like to thank you, and I think we can pass this over to the next person. But thank you for the opportunity to be here, everyone. I really do appreciate it.
So we go further, or what? I was going to ask something.
Yes, of course. Yes, of course.
We have some time, so we may discuss. So producing this fiber is a very important thing, I believe. So as far as I know, there are only 2 places in the world that can produce fibers.
That's correct.
You are the 3rd one then.
That's correct.
So how this will affect your business? Probably accelerate or have a good impact if you produce your own fiber.
That's a fair question. Thank you, Professor. I think what we've tried to do is really just eliminate the risk of supply with this. There's a suggestion based on what we've seen so far that the quality of the product continues to improve by doing it this way. But we're not necessarily doing this so that we can penetrate newer markets. We will continue to try. However, the real idea here is to make us less dependent on a single supplier, right? As you pointed out, there's one manufacturer for all the fiber in the market. So up until we started introducing this on Affinity, the only other manufacturer that was making their own fiber was Terumo, which was a wise move, right? They bought Mitsubishi and they've continued to develop that technology, and we believe that was a wise move. So if imitation is truly the sincerest form of flattery, then you can say that's in this way we're very much mimicking what Terumo has done. And it's not just about the quality; it's about the stability of supply. Again, during COVID, it was exceptionally difficult for all of us to get fiber, especially ECMO fiber. So we believe that going this route is going to help us to really stabilize the risk to you guys when it comes to anything similar to a pandemic or anything that would be a force majeure or a natural disaster.
Thank you. And I was just going to ask the oxygenator shortage, especially we felt very much strongly in our country. So Turkey is a market of about 90,000 open heart cases in a year. And in the last 3-4 months, sometimes we need to stop the operations so we don't have oxygenators. So what is the reason, and is there any solution?
Yeah. So, and there has been an acute shortage, and it depends on what manufacturer you speak with. But we've had some problems with silicone across our industry. And if we can't supply the tubing sets, we can't supply the oxygenators. That's definitely had an impact in your country as well. But specifically in our case, we have also seen that one of the major manufacturers is kind of pulling back a little bit from the cardiac surgery market. And we have all collectively had to fill that void, all of us. So Eurosets, us, LivaNova, and Terumo. And when you have that, when you have one of the companies that has historically been in this market for a long time, really just change their business model and decide that they're going to do something differently, that has an effect on all of us. And when we were already at kind of the maximum in terms of our capabilities of manufacturing oxygenators in the United States, that has a consequence downstream for everybody. I live in Mirandola, so two of the other companies are based there, and we often talk to each other because it's a small town. And we're all having different issues, but we're all having issues. And in many cases, it's simply either sourcing fiber, sourcing silicone for the custom sets, and most recently in our case, just being able to get PVC from from Dow Corning. As I don't want to throw any of the other businesses under the bus, but certainly one of the problems that we have with PVC is that we compete with Apple and we compete with General Motors for PVC. Yeah. And so you can imagine that Apple will say, well, I'll pay 10, 15, 20 times what Medtronic is paying, for the PVC, because they know they can pass that on to the consumer. It doesn't work that way for us. So we're stuck. We're at the tail end of what should be allocated to us, because the market dynamics is just not being allocated to us the way it should.
Thank you.
May I make a comment, since we're discussing about Medtronic and what Medtronic has done so far for this technology, going a bit away from what we're discussing now for senators and all this stuff. I would like to bring forward how much the interaction between our society, MiECT, and industry has brought up results. I remember last time that we had this meeting, Alberto Tassi from Eurosets actually declared that some of the devices or the materials that they have created are due to this society and our initiatives and our research. And that's why the title Research and Development means that how much research is influencing development, and especially from the industrial standpoint. And I would say that Medtronic is actually not just hearing, but is testing or developing its devices through this research coming from MiECT key opinion leaders. And I can witness that with the new model that we are using, this heart lung machine, the quantum one, which is software based and is really a new generation regarding perfusion with a lot of tools. Having this complex modular systems that we are using, as Ashraf have pointed out, we need to have some plug and play, let's say, components that would facilitate perfusionists to adopt these complex circuits with a lot of, short circuits that facilitate any kind of, let's say, conversion or volume adding when there is any kind of suction effects and so on. So I really want to thank Mike Van Driel that is giving us the opportunity to actually develop more handy, more versatile systems for perfusionists, for our customers that are actually the patients, so advancing patient care with this interaction between industry, societies, and of course, all the users of this technology. And thank you for this.
That's a pleasure. But I'll take this, that one thing I would like to just point out as well is that that some of the smaller companies that have the ability to really react quickly, like Eurosets, like certainly like Spectrum Medical, that they are really doing a great job bringing out some of this technology to the market in a very, very fast way. So it's not just us, but but thank you for that compliment. There's a lot of us in industry that are all working in the same direction to make everything that we learn here possible.
Okay, so we go on now. Andreas Becker from Terumo. He's marketing director of cardiovascular. Hi, Andreas.
Hello, Serdar. Hello, everyone. Good afternoon, good evening. Always a pleasure to join this excellent meeting. Even so, it is remotely this time for me again, but already now I think I can congratulate you to the great program and very interesting presentation so far. Thank you very much. I'm also happy to share our development activities around MiECT. Let me try and share my screen. So here we go. I believe MiECT and the industry is sharing a common goal. We both want to increase the biocompatibility of cardiopulmonary bypass and also to minimize the adverse effects. When we talk about adverse effects, what are these? I believe we can all agree the three probably most important is the hemodilution and potential need for blood transfusion, the systemic inflammatory response, and removal of embolic factors that may be present in the extracorporeal circuit. So whatever we do in development, we try to minimize these adverse effects. In Terumo, our development strategies are mainly based around oxygenators and other components for extracorporeal circuits. This is our core competency. Later in the presentation, I will introduce two new members of our product portfolio, one oxygenator and one centrifugal pump, where we followed the MiECT principles. On top of that, we are also developing related technologies. So we believe that physiological or more physiological extracorporeal perfusion is only possible if we closely monitor physiological parameters in real time. Only such monitoring allows to take an early intervention in case one of the important physiological parameters would trend outside of physiological levels. Recently, we are also investing more in surgical techniques, and related to MiECT, already during the last update meeting, I mentioned our endoscopic vessel harvesting system that allows to harvest veins or also arteries, saphenous vein, radial artery in a less invasive way compared to the open procedure. Also here we have new clinical evidence that I will share later. And my last point, and Mike already touched on it, we need to make sure that supply of MiECT technology is reliable. Probably 2 years ago, when we had the last update meeting, I would not have even thought about this point, but it's now really impacting also our development activities. I'm pretty sure many of you, if not all of you, experienced some degree of supply limitations, even supply interruptions. So this is impacting also our development. What we try to do is, especially for MiECT, to move a little bit away from fixed designs and go more for individual components, offering choices to our customers so that customers can pick and choose the components that best fit their circuit and come up with their own design. And we also take care to develop components that can be used more universally. What that means, I will come back also in a minute. I said I'm going to introduce two new products, one of which is the new NX19 oxygenator. Also here, I'm addressing the fiber. It was mentioned already that also Terumo is producing its own fiber. Obviously, the benefit is that we can also modify and optimize the fiber. And for the NX19 oxygenator, for the first time, we have used a new, smaller fiber compared to the current industry standard. This fiber not only allows to reduce the priming volume, actually the NX19 is currently the smallest full adult oxygenator available. It also increases gas transfer efficiency, allowing us to use less surface area to have the same performance and even a lower pressure drop. Also with this product, we are moving forward. There is now a first scientific publication available that confirmed the clinical safety of the product and also verified the performance characteristics that we are specifying. So in our eyes, this is a truly MiECT product. It has a lower priming volume, meaning less hemodilution, less AKI. We have less surface area, so there should be a positive impact on inflammatory response, and the product has an excellent air removal or emboli removal characteristics. So we are confident that this product can contribute to better patient outcome, less complications, shorter hospital lengths of stay. And it's also for universal use. It can be used for a very broad patient range based on the low priming volume. And it can also be used for MiECT as well as traditional perfusion. Moving on to the new centrifugal pump. This is a pump with a new highly efficient impeller design, have low heat generation and low hemolysis, and also a new port design. But probably the most important factor is that this is the first centrifugal pump with multiple use indication. It can be used on different heart-lung machine platforms without the need of a special adapter. So it's indicated for use, obviously, with our own Terumo System 1 heart-lung machine platform, but it can also be used without an adapter and is indicated for all LivaNova centrifugal systems. And talking about universal use, centrifugal pumps, typically they are not compatible with any competitive centrifugal motor platform, which is causing a risk, especially in times where supply is not running smoothly and we are facing all types of raw material shortages. So with this development, we really see a step forward to ensure supply, even if one or the other manufacturer is facing a problem with their centrifugal pump head. I already touched on our CDI, online blood parameter monitoring. So this is also a technology that we are highly recommending for MiECT to have a close monitoring in real time of essential blood parameters, so that corrective action can be taken immediately in case one of these parameters would move out of the normal range. It's a clinical proven technology, is on the market for many years. And there's also literature showing that using this online monitoring is improving patient outcome. The last product I would like to touch is the endoscopic vessel harvesting system, the VirtuSAF, which really offers benefits for the patients as well as clinicians. For the patient, it's very obvious, not only the cosmetic result compared to the open technology, there are also reduced wound healing complications, less postoperative pain, and a shorter hospital length of stay. And just last year, there was a publication looking into the health economics of this system. And it was actually demonstrated that endoscopic vessel harvesting is cost effective. It even has a cost advantage over the open vessel harvesting technique. And this is a good example where we can even show that minimally invasive technologies can be more cost effective and can result in cost saving. Very often we hear as an argument against MiECT that circuits would be more expensive. Which may be true. Also, the endoscopic vessel harvesting system, the initial investment is higher. This is true. But if we consider the results and the long-term outcome for the patients, less complications, then we can demonstrate even a cost saving for the hospital. And this is a very nice paper demonstrating that the endoscopic, the minimally invasive technology is superior to the open technology. And I'm pretty sure that we will come to very similar results if we look for MiECT circuits. Before I conclude my presentation, and this has also been touched many times before in the previous presentations, we need learning and education. This is for sure. MiECT is a change of concept and it is a team approach. So education is essential to overcome the initial learning curve. We also have multiple activities. We organize workshops, wet lab training sessions, using simulation. We also expanded our clinical support team. We have experienced perfusionists and also physician assistants in our team to support. We have an extensive online learning program also on MiECT technology, and we run webinars both live and on demand. And this concludes my presentation. Thank you very much for your attention.
Thank you very much, Andreas. So now you have everything, each component of the MiECT system, but you don't have any customized pack, right? One single pack for MiECT, like other companies, some of the other companies. Because Terumo was the first company to bring MiECT system as a package.
Correct. And well, it is still available. So we had a couple of fixed design, as you said, full packages that are ready to use, fully pre-connected, can just be mounted to the heart-lung machine, and then perfusion can start quickly. It has been also a modular system, so depending on the application, accessory packs could be added to also perform valve surgery, for example. But we realized that many centers were anyway not using this fixed design and preferred to customize their own circuits. And we are still supporting this. Especially in times where we are facing supply issues, it's kind of risky to have one fixed design that is composed of many individual components. If then only one of these components have a shortage, and Mike mentioned it, we were facing shortages for silicone tubing, for example, even for plastic resins that were short, then immediately the whole product is at risk. If we go more for individual components and we offer choices, then customers can still pick and choose what is available and can configure their own circuits. So based on the experience of the past years with all these supply issues, we are now favoring the second way, moving forward more with customized circuits rather than one fixed design.
So do you suggest any, let's say, bubble trap or any other accessory requirements with this customized circuits? Because you have, like, as you said, centrifugal pump, new oxygenator, everything is okay. How about the safety?
Yeah, obviously, whenever we customize a circuit, we listen to the account and to the requirements that the account is expressing. Talking about the bubble trap from a company perspective, we would definitely recommend the use of a bubble trap. We consider this an important safety feature to trap air and particles that may come down the venous line. So from our side, we always included a bubble trap into our circuits as an additional safety on the venous side of the circuit, not having an open reservoir available.
So this looks like a very interesting, let's say, alternative, because if I want to customize my mini circuit by using Terumo products, I can use it on any pump, right? Because I can use the oxygenator. So centrifugal pump is, as you said, compatible with any heart-lung machine. So I can configure my own system and put, for example, S5.
This is correct. I mean, it's not compatible with any heart-lung machine. It's indicated for the Terumo System 1 and for the LivaNova heart-lung machine platform, which is certainly the majority that is out in the market, that's for sure. But it is not compatible at this point with any other heart-lung machine platform other than the two mentioned.
Okay, thank you. Yes.
Oh, sorry. Can I just ask a question about what's your if you're looking at centers that do mini bypass, like what percentage of your cases of your that you have are actually centers doing mini bypass? Do you know?
Well, it's difficult to say. I would be pretty much with Polychronis when he said it's definitely not more than 20%. But what we see is that the borders between a MiECT circuit and a conventional circuit is nowadays not very clear anymore. So what we see is that many centers that are doing what we would call a traditional perfusion, they are still following MiECT principle. They try to reduce priming volume. They try to reduce foreign surface area wherever possible in selecting optimal components for their use. So it's getting more and more difficult to really differentiate. Also, if you would see a class 4 MiECT circuit, I mean, it basically has all the components that are also present in a conventional circuit. But you know, I know what your principal question is. So I would say for us, probably it is somewhere between 10 and 20% MiECT use compared to all extra information.
Okay, thanks.
Any other questions? No. Okay, thank you, Andreas. Thank you very much.
Thank you, Sada. Have a nice evening.
So we go now to Simone Salazari from Livanova. Is he here? Yes.
Hello.
Hi, Simone, how are you?
Hello, I'm fine, thank you. So it's a real pleasure for me to be with you, even if not in person. So good afternoon and good evening. Thank you very much for your kind invitation. I will need the organization support because it seems that my internet connection is not good enough, but I will try to complete my presentation. So as you know, we have recently launched, starting from the first global markets, our new Essence perfusion system. So my today presentation will be focused on Essence. Next slide, please. So today I would like to share with you the Essence journey from the why, next, the new era of perfusion, through the how, the user-centric design approach, to the what, the Essence perfusion system. So next, let's start from the why. So let's start from the new era of perfusion. So thanks to technology advancement and an increased focus on patient outcome, perfusion and the role of the perfusionist are changing and are entering a new era. An era in which the spotlight is on the real value that perfusionists can bring to clinical practice through the combination of intuitive technology and accurate data. We, as market leaders in cardiac perfusion, have the responsibility to listen to you and to anticipate your evolving needs and provide solutions to support you in your life-saving role. Next one, please. The how. Essence built following a user-centric design approach in order to meet your real needs, your current, but also your future needs, and support you in achieving better clinical outcomes for your patients. Next one. As mentioned before, we listen to you, giving voice to more than 300 customers worldwide, not only clinical, but also non-clinical stakeholders. Next. So how did we develop Essence? With S5, we had a very strong legacy system in terms of safety and reliability. The two most important attributes that perfusionists recognize in a perfusion system. In the last 15 years, we installed more than 7,000 S5 units worldwide. So that's why we decided to meet customers, to meet you, all around the world in order to understand what was working well on S5 and what could have been improved, in order to make your daily work even easier and to support you in achieving better clinical outcomes. We have observed the perfusionist in order to learn. We have analyzed your behaviors, your activities, your actions and workflows, collecting all the feedbacks during the design and the development phase of Essence. Next one. So an unprecedented co-creation journey from the discovery and design phases through the deployment and then the evaluation one. As mentioned, so far we have cooperated with more than 300 customers, but the work is clearly not over. We will continue to engage you to make sure that Essence continue to grow and to remain an essential and valuable presence in the OR. And now the what, so the result of our journey. Next, please. There's no audio.
Bridging decades of proven performance, an enduring commitment to safety and reliability, and the precision you desire to provide meaningful data. Essence Perfusion System.
Next one, thank you. So the Essence Perfusion System is a state-of-the-art hardline machine with an integrated patient monitor and accurate sensing technology for data-driven decision-making. So not just an HLM, but also, next, the innovative Essence Cockpit, the central control unit, the brain of the machine. Next, the advanced patient monitor that is, as mentioned before, fully integrated in the Essence Perfusion System. So each machine will be equipped with the Essence patient monitor and with the GDP module, let's say, fully activated for each of the centers. And next, the closed software platform in order to protect data and safeguard its integrity and quality. Next one. So we are particularly proud of the fact that Essence is the first heart-lung machine fully conceived and launched under the new European MDR requirements. What is our Essence value proposition? Next one. It's, as said, it's elevating perfusion into the new era. So Essence is built on LivaNova 50-year legacy of safety and reliability. This year, we are also celebrating our 50th anniversary in cardiac perfusion. Essence supports the perfusionist in doing what is best for each patient and allows the entire heart team to continuously improve the clinical practice. Next one, please. 4 pillars support our value proposition: safety and reliability, patient-tailored care, intuitive technology, flexibility, and efficiency. Let's have a look at some of them that may have a positive impact on MiECT procedure, on MiECT strategy. Next one. So the mass-mounted pumps allows to optimize the position of the disposable, the oxygenator, and the tubing set in order to minimize priming volume and reduce hemodilution. Next. As mentioned before, in addition, the Essence Perfusion System allows perfusionists to implement the goal-directed perfusion strategy through its official formula in order to provide insightful data and enable patient-tailored care in line with the more physiologic perfusion. Next one. Here, an initial feedback from one of the centers involved in the limited commercial release. We recently completed the limited commercial release in some of the European markets. And here is one of the feedback that we collected immediately after, comparing the tubing set length between Essence and S5. As you can see, the reduction, thanks to the full mass-mounted system that Essence is and its smaller footprint, can be very relevant. Next one. So thanks to the versatility and flexibility of the Essence perfusion system, and next one, its advanced profile management, each center can really create full customized hardware and software configurations based on the specific needs of its patients, workflows, and user. We can, for example, create a profile, so a software configuration dedicated to MiECT procedures with the centrifugal pump as arterial pump, the kinetic assistance, venous return, and all the other components that are usually used in a MiECT procedure. Next one. So during the Essence journey, we had the privilege, and we also had the opportunity to see almost all the possible configuration. Next one. Here we have some real example of flexibility, modularity, and versatility of the Essence perfusion system coming from the centers involved in the limited commercial release. Next. You can see how many different fully customized configuration we can create in terms of orientation, pumps and accessories selection and position for open and closed circuit, for open and closed systems in both adult and pediatric settings. Next one. As part of the full Essence experience to enhance our customers' purchasing experience and streamline the ordering and operation processes, we have also developed a brand new configuration tool, the Essence Configurator. Next. To support you in fully customizing and designing the Essence solution of your choice. Next one. In conclusion, we are just at the beginning of our Essence era, so more to come. Please stay tuned. Thank you very much for your kind attention. That was my final slides. So thanks again for your kind invitation. Thank you.
Thank you very much, Simone. So I just see the demonstration of the Essence in US. I didn't see it, on the operation live, but in order to use for the MiECT purpose, do we need to also change the software or only configuration?
No, it's just a matter of configuration. The system is based on the profile concept. So based on your hardware configuration, so the component that you included in your configuration, you can easily create a software configuration, so a profile, just with the component that you will need during a MiECT procedure. And you just need, without disconnecting any hardware component, you just need to upload the MiECT configuration, software configuration, and you can start using it in a MiECT, in a minimal invasive extracorporeal configuration setting. It's a software-based system. So now we moved from the hardware-based system that was S5 to a software-based system that is Essence.
So if we set up this software or configuration, do we need to use again the LivaNova MiECT system or any system?
You can use any system. You can use any system. It's okay. In LivaNova, we have specific components that can support you in the MiECT procedures, but different other disposable can be used in order to support you during the operation. Absolutely.
Okay, so I also want to ask your business from the specific LivaNova product for MiECT. So how many centers do you sell those packs? Or how many centers do you know they're routinely using those MiECT systems?
It's really very country and regional specific. We have some markets in which more than 50% of the procedures and the center are using MiECT. In other markets, this percentage is very low. So I can echo what my colleague said. So on average, we can consider around 15-20% overall in the international markets. In some centers, in some countries, this percentage is very, very high. Close to 80%.
Do you sell it in Europe or anywhere except Europe, like in US or?
We sell it mainly in Europe and mainly in Northern European countries, but the percentage of MiECT, or at least the trend towards a minimally invasive extracorporeal circulation is increasing in terms of hemodilution reduction, in terms of tubing length reduction, as mentioned before.
Yes, thank you. Any other? Yes.
Simone, great presentation. I just have a question, just a follow-up, basically to Serdar. So when you say it's programmable, so you can have like for MiECT, we want a automatic air purge system, right? Air purge controller. So you have an automatic air purge controller built into this? Where
Not at the moment, let's say, integrated in the Essence perfusion system. It will be one of the next component that will be introduced on the Essence perfusion system. As you can imagine, as we launched the system a couple of months ago, we are, let's say, in our priority list, we have different components that will be fully compatible also with Essence, and the air purge control system is one of the first one.
Okay, so basically,
yeah,
if you're doing mini bypass now, you won't be able to use Essence.
Yeah, the venous bubble trap is already available. The air purge control will be available in the near future.
Okay. Is there anything else that you're building in that's specific for MiECT?
Specific for MiECT?
Yeah.
Not specific for MiECT, but as mentioned also some time ago, we are working on other products that will support us in the near future. So Essence will be our future cardiopulmonary brand, our future cardiopulmonary portfolio, and we are working also on future Oxy family that will support even better what we have today also on MiECT procedures. That will be something that will arrive in the coming years.
Okay, thank you.
Welcome.
In my point of view, it's not only count the circuits that the perfusionist designed, but also the facilities that the heart machines offer, as well as the safety issues. More specifically, it's paramount importance how the device deal with air, how many flow sensors the device have in order to have an image about the preload and afterload of the perfusion.
Yes, for what concerns flow sensors, compared to what we had on S5, we have now the possibility to measure 3 flows. So we have the possibility to measure all the different flows. So not only the venous flow, but also the arterial flow, not only with the centrifugal pump, but also with the roller pump. So in this direction, we increase the safety profile compared to what we had on S5.
Okay. Okay. Thank you, Simone. Thank you very much.
Thanks to you. Thank you very much.
Okay. Thank you. Thank you, Simone. So we can move now to Hans Seller. He's a great also proponent of minimally invasive corporal technologies, and also a dedicated perfusionist and entrepreneur in promoting simulation in perfusion. So Hans, please show us your research and development project.
Thanks very much, Polychronis, and thank you for having a simulant here in this meeting. Most of you are familiar with this Califia system. This is a patient module, and in the meantime, it is quite popular, and it is the awareness of people is now increasing, and it is in newspapers, in TV documentations, and it's like here in Bad Oeynhausen with Professor Gummert. And for me, the best or one of the most significant developments in the last year was the add-on these Califia lung. I think the anesthetists here in the audience will agree that it is not only perfusion, it is a little bit before and a little bit after the perfusion, especially before and after the coffee break of the anesthetist. And this is a synchronization of the lung simulator with a patient module, and all the changes in the ventilation are reflecting in the perfusion and vice versa as well. So in ventilation, we have 30 different parameters, and very important for me is here, especially in VV ECMO, is to see the relationship between alveolar ventilation and the blood flow through the lungs. And right now we only have the pressure mode for the ventilation, but the volume mode is coming up, and you can see here the volume pressure curves on the screens. My question now is, shall we invest in future simulation technologies? I think yes, we should. I think the stone age of training and education is gone. And also the typical type of education with PowerPoints, it will be sooner or later obsolete. We are looking into new technologies. Here we are starting our starting sequence when we go into the corridor with the washroom, and then we decide whether we want to go to the left to the OR or to the right to the ICU. The guys in the background are drinking water all day long. Diabetes, obviously. And we have a new opening screen here. It's more easier to operate. And if we look, for example, here on the ICU, we can integrate all kind of media files. It can be X-ray pictures, it can be ultrasound video clips, it can be MRIs or CT scans. If we move a little bit forward to the ventilator is fully functional, of course, and all the settings we are making reflects immediately in the blood gases of the patient. And another feature is the INVOS. Later on, some more details about this here. INVOS, I know that the group from Thessaloniki here has a very sophisticated program for teaching INVOS, and here our INVOS system, I just turn it on now, and then we are selecting some sensors here, and we place the sensors on the head of the patient. Of course, we have a choice between different sensors. Click the cable on, ready. If you use an ECMO patient, we can also place another. It's a 4-channel monitor. We can also place the sensors on the legs of the patient. And when I turn it on, it's not very good, the cerebral saturation right now. I can control in the background different features. It's very high advanced. I can create a background noise for the sensors. I can create a resistance which is equal to the density of the bone. And of course, I can also regulate the metabolic rate of this patient. And with these features, I can manipulate the results. And when I turn it on, then it is working. Blood gases, we call our nurse, and the nurse is coming, hopefully. Yes, here it is. And he's asking what he should do as I'll run a blood gas. We have 9 different spots where we can take blood gases from the patient. Then he disappears, is going to the lab, and it's relatively fast, and the results are coming up here on the patient chart and of course, you can also print out these results. When we call our nurse again, he's coming again, and he's asking again what he should do. By the way, we had a female nurse first, but the complaint was the female nurse was too sexy. Now we have a male nurse. People are complaining again, and now we have to generate a gender-neutral nurse. And here we are giving red blood cells, and it is not only an optical gag. When we give a certain amount of red blood cells, it is influencing the hemodynamic of the patient. It is influencing the total circulating blood volume, the hemoglobin and the hematocrit as well. Good. We can do different 3D animations, and all kind of 3D animations can be integrated in a scenario with one mouse click. This lousy computer here, it looks like nothing, but it is a high-end gaming machine with 6 gigahertz speed and a RAM cache of 64 gigabyte and the highest speed for a GeForce graphic card. Oxygenators, we can even play with the most advanced oxygenators like the Nautilus here from Medtronic. We turn it on, it is fully functional, of course, and it shows us the delta P, and in the background, of course, we can manipulate the delta P and the resistance across the fiber for these oxygenators. And we can do the same training also in an AR, augmented reality training program. The little robot here will guide you through this whole training of the device, and a tutorial in the screen or in the Google will show you how to operate the system, and we can do it the same also in a remote way, augmented reality in a remote training, like here for the cannulation of the jugularis vein. And we can transfer these kind of trainings via a new app which is called REMAID into any place in the world, and I can do my training from the OR in Hollfeld, where I'm living, to Congo or United States or wherever you want. This was a joke because in my village is no OR. Cannulation in virtual reality, it looks like this here. We can do it in a real mode or we can do it in virtual reality. And here is another example. I put a femoral cannula in, and with this tracking window, we can follow the cannula and we can find the final position of this cannula. And of course, I can see the full picture of a real patient in the HoloLens, or now since a couple of weeks in the Magic Leap #2. And we can also do a complete remote training for devices like this ECMO machine here in augmented reality. The only thing you need is the QR code of this machine somewhere on the door, on the wall, and then you see the real device and you see the instructions, and it guides you, the tutorial guides you through the whole procedure, how to set up the machine. And these guys who are developing these kind of augmented realities, they are not coming from the medical field, but they are now able to prime a system completely without any guidance. And of course, we can do the same in virtual reality, the same device here again, and it is fully functional. And you can do a complete training on a device even before it comes to the market or parallel to the launch of a device, machine, ECMO machine, heart lung machine, or whatever it is. We can implement medical imaging here. It's not very clear to see, but here you see the cannula going up into the vena cava. Another type of visualization of flow would be this here. This shows here the velocity and the magnitude of the velocity. And if you would have a HoloLens, you would see also the calculation for the kinetic energy, which is needed to drive the fluid or a medium through a cannula or through a vessel. And another example here for CFD, we put a cannula here in the femoral artery, and you see the critical points showing by CFD imaging in red. So this means these are the critical points where a kink could occur, or where we have a higher velocity or a turbulent flow. With these imaging, we can also create some 3D environments, like here, based on a patient CT or MRT. We can create a 3D model of the right atrium, and then we put a cannula in, and you see here on the X-ray picture, you see the cannula wandering down, and as soon as the white dot turns into green, like now, yes. So then you know your cannula is in the right position. Another add-on to the Califia system is the beating heart module. With the beating heart module, you can make a heart out of silicone or a heart of an animal beating. And these two guys here, they are cannulating the first time in their life. And the whole cannulation process took about 45 minutes. Doesn't matter. The sheep is already dead. Yeah, so don't worry. Anyway, it's a nice tool to practice, like on a thorax block. Thorax block is the lung and the heart of a sheep. A new technology allows us to so-called frame grabbing. It means we are taking pictures from an ultrasound machine directly into the HoloLens or in the Magic Leap, and without the detour of a computer. And today would be a perfect day for simulation, because it's a little bit cloudy outside, and Califia is now available also in the cloud. Means the software, you only need to install a remote desktop on your computer, and then you can access the version in the cloud. I'm always pretty much in favor during the simulation session to record all the conversation between the teams. And I think for mini bypass, it is very essential that we are having a really, really good conversation between the parties involved in these procedure. It's just to avoid some misunderstood between the people involved in the procedure. Another new thing which is coming up is the areas of interest. You see here a heart-lung machine, and these are different monitors, different spots the perfusionist has to look at. And we are collecting data, and this data collection is, we call it clustering, means it's an eye-tracking camera, and we can follow immediately what the perfusionist is looking at. Is he looking to his machine, or is his interest more the nurse? And the output is like this, and out of these wonderful, colorful pixels, we can create 3D pictures and 3D models. And one example here for the areas of interest. Here, the perfusionist is looking very nicely to all the components of the heart-lung machine. And here, obviously, something happens. His focus is on the blood gas monitor here, and he's looking now to the tubing. Obviously, he wants to solve the problem, which is created by the tubing set. So what's coming next? We are moving more and more into a modern world. This picture is a little bit fuzzy. Maybe you have seen this picture recently, the Pope in this white winter coat. It was a fake picture. This picture is also fake. The machine is not existing. The patient is not existing. The nurse is not existing. It is all made by artificial intelligence. Here it looks already a little bit better. Now we have already a kind of pool of 90 different avatars. And so the outlook is we have just established last year the society, which is called SCI. It's a new chapter in Euro also, and I'm happy to be part of this chapter. It means simulation and artificial intelligence. So with this picture of another simulation scenario, I would like to thank you for your kind attention.
Okay, thank you, Hans. I think this was one of the most impressive presentations that you've done in the MiECT update meeting. So it seems that there is a huge potential for virtual reality and artificial intelligence. But this meeting is real now. Okay, so okay, we will keep doing real meetings, but definitely artificial intelligence is in front of us. So I would like to ask if there's any question from the panel, or yes, just Marwa.
Thank you for your impressive presentation. My question is, for you, do you know the cost of these type of simulators?
Well, the basic perfusion simulator, it is a combination. It is perfusion and ECMO combined in one device. You can attach every ECMO machine, every heart-lung machine to this device. The price depends on the country and on the local distributor. Yeah. So, the normal strategy is that a distributor is multiplying the price by 2, and with these 2% margin, he has to survive. Yeah.
Okay. And my other question is for the senior surgeons. For those who practice simulation at your centers, how do you implement the simulation in your residents' training? Do they have time during their training to go to simulator? Do they access simulator? Is it specific courses that you decide that they have to do? Or is it just if they have time, they get to the simulator? How do you manage that?
Have simulators in our institutions. We are in the process of acquiring the Califia simulator for our perfusion program. Okay, so we're trying to liaise this with our university, as I told you before. So to integrate, let's say, simulation from different disciplines, like cardiac surgery, possibly ophthalmology and all that, and have a simulation program in medical training, in medical education. So this is a nice product that we hope that it will get funding from the EU, because the cost is not, is pretty high for the for especially for Greece and for the time being and the financial crisis. I don't know if in Germany you use simulation in cardiac surgical training.
Polychronis, it's less for surgical, but you have seen these sequence with these heart of a sheep. This is from the Vanderbilt University in Nashville, and all the young surgeons are obliged to perform a simulation training every second month on the simulator. And for perfusion schools, it is different. Some are doing these once a quarter, some of them like the Midwestern University in Phoenix, Arizona, they are starting with simulation from the very first day of their education. And it goes all over these 2 or 2.5 years, and they sitting at the simulator at least once a week. And when they are coming into the R, every one of these students has already done 50 or 150 cases. And this is a huge benefit in the education.
The German society has simulation training. It's not obligatory, but it's mainly focused on surgical technique. How would I implant an aortic valve? How to do the stitches? How do I do an anastomosis for a coronary? Our center, we have a simulation lab where we have sets of instruments and needles and threads, and they can simulate an anastomosis. They can access that anytime. It is managed by the residents themselves, by the trainees themselves, and 3 times a year we have 1 day dedicated where the seniors, most of the senior surgeons train on 1 or 2 specific surgical procedures. Even if they're advanced surgical procedures, aortic valve reconstruction, and the trainees aren't so far yet, but it is a nice experience for them to know how in detail how is this procedure done, what are the tricks, what do you have to take care of, why are there a few different techniques of doing things. It is definitely encouraging. It is not they're not obliged to do that, but specifically coronary anastomosis, you noticed relatively quickly who was frequently simulating an anastomosis and who wasn't. Sometimes you think, okay, this trainee hasn't performed. We don't have a dedicated system of mentoring. So if we have 5 trainees in the department, one day they'll be with this consultant, one day with that consultant. And sometimes when you don't perform a cabbage with a trainee for two months, and then you see him again and you think, okay, this is much better than last time, you definitely know that he was in the simulation lab.
Just one more comment, Kyriakos. The initial idea of the simulation system was not to teach some haptic actions. It was to teach physiology. I'm getting very often a request, mainly from Arabic or African countries. Mr. Hans, we need a simulator. I said, what you want to simulate? Change out of oxygenator. I said, you don't need this simulator. You need a bucket with water and 2 pieces of tube. That's it. And here we are talking about physiology. We are talking about 64 different parameters from perfusion and another 32 parameters which are coming from the mechanical ventilation. And this is the main purpose of this simulation system.
Just to finalize what you are discussing for Marwa, we have done several years training courses on MiECT for Medtronic with Califia simulator, and I would integrating into our program. And I can tell you that was the most popular part of our training. So it's something very easy to apply repetitively, do a lot of scenarios, play with it, and Apostolos was there, and it was really, let's say, the core part of our trainings throughout the years. Unfortunately, that was before COVID, and it was not such advanced systems at those times, but still it was really very nice to have simulator in your training courses. It was very good.
Well, yes, you're right, Kyriakos. The pre-COVID and the post-COVID software, it's a difference like day and night.
Okay. So thank you all. Before we we go to the next session, I want to pay a tribute for this session to someone who was from the first beginning with us in this society, and he made a huge effort for us to keep on. He was one of the key persons for MiECT, supporting all our initiatives, and especially the meetings. And for this one, the update meeting, he is the main sponsor all these years. So I want to award Mike Van Driel for all that he has done so far for MiECT, and I hope he will be with us with his commitment, his vision, and also his friendship that we managed to have throughout all these years. So Mike, if you can come over here.
Can come here.
Okay.
Just for a second.
This is something from MiECT. Me and Polychronis, and of course all the board and the steering committee for what you have done so far, and I really appreciate all this. Thank you.
Well, look, I'm accepting this. Thank you. This is quite an honor, but look, I didn't expect this. I'm a little embarrassed. So, for everybody that's here, thank you. I don't even know what to say. I will put this in a place where every time I close my computer as I run out to the airport, I can see it. I'm gonna put it that way. So that means I'll see it every day. But thank you. This society means the world to me. This technology, MiECT technology, and it's one of my direct reports was just asking me, so what are you doing? I said, well, I'm actually spending a Friday evening with people that I really care about, and it's not my wife. So thank you for everybody. And look, I accept this on behalf of not just me, but Medtronic for sure, as well as all the other manufacturers, because we all do care about advancing in all of our own ways. We're all advancing what we're doing with on-pump surgery. So thank you for letting me be a part of this. And thank you both.
Thank you.
Thanks
Thank you. Thanks a lot.
Thank you. Sure.
Yeah.
Absolutely.
Yeah.
Okay.
I will move here.
Thank you.
Okay, so John, we can go on.
Give him a sandwich.
Well, I think we've had quite a good session so far, and we'd like to complete this evening's presentations with what I think is probably one of the most significant accomplishments of this society to date, and that is the first randomized comparison between mini bypass and conventional bypass circuitry. And so to present these results, initially, we have Professor Angelini from the Bristol Heart Institute and Professor Barney Reeves from the University of Bristol, who will be presenting the results, and then we'll have some comments from the remainder of the board. So if you want to carry on, gentlemen, please.
Good afternoon, everybody. I hope you can see my slides. Can you? Can you see my slides?
Not yet.
Not yet.
Well, in that case, I don't know what to do. Because I've just been connected. Okay.
Here you are.
There we are.
We got you.
Okay. So we're in business. Okay. Just give me a sec. Right. Can you see them now?
Yes. Perfect.
Thank you very much, everybody, and to give us the chance to present the results of the conventional versus minimally invasive extracorporeal circulation, the COMIC trial. I will just go briefly through some of for the people who are not familiar with this, the aim and objects. The aim was to test the hypothesis that MiECT is effective and cost-effective when compared to conventional cardiopulmonary bypass for adult cardiac surgery. And the objective was to estimate the difference between the two techniques in the percentage of participants having the primary composite outcome at 30 days. I'll come to that in a minute. Also, we were interested on estimate difference in secondary outcome. Now, just to remind you, this is the list of the 12 primary endpoint. And as you can see, they are all pretty clinically relevant, going from death to serious septicemia, prolonged ventilation, and so forth. And the secondary outpoint were blood product transfusion, length of hospital stay in the ICU, and overall hospital stays, other serious event, and quality of life. Now, this is how the trial was actually designed originally. So all patients having CABG, AVR, and CABG plus AVR. And as you can see, it was quite ambitious. We wanted to recruit 3,500 patients. And I'll come to that in a minute, starting by presenting the consort diagram. Ultimately, the study was stopped. We managed to recruit almost 1,100 patients. And the reason why it was stopped was, first of all, we could not recruit enough patients per month. But perhaps most important, the COVID. COVID is really what is stopped everything for a good 2.5 years. And therefore, and this is probably one of the main reasons why the trial was stopped. However, we were able to randomize patients to the two groups, 536 in the conventional cardiopulmonary bypass and 535 in the MiECT. There were a few withdraw and a few lost the follow-up, but as you can see, if you look at primary outcome, we had 522 primary outcome for the conventional check and 517 for the MiECT. What is interesting is these bottom figures. 2 patients in the conventional cardiopulmonary bypass ended up receiving MiECT, and 15 patients in the MiECT ended up receiving conventional cardiopulmonary bypass. There were some other reasons for not receiving either conventional or MiECT, like, for example, the surgeon said, I have to do this operation off pump because whatever, the ascending aorta is calcified. I got a whole list of these if you're interested to see it, but they are not particularly exciting anyway. The bottom line is we had a good randomization and we had a good primary outcome availability. And this is the time of procedure. As you can see, the majority of patients had coronary surgery, fairly straightforward coronary surgery. 9% had AVR and 6.5% had a combination of AVR plus CABG. This is probably one of the reasons why we found that our percentage of primary event was much lower than when we had designed the trial based on a previous randomized study, the Title II, which included all comers. To cut a long story short, probably here there were a lot of straightforward cases where obviously you don't expect to have too many complications. This is the baseline characteristic. Do not bother looking at these slides. I put it on simply to say that as you would expect when you randomize more than 1,000 patients, we had a good distribution and similarity between the two groups. And this is really the key figures, the risk-hazard ratio for first and secondary outcome. Now, if you concentrate on the top part, this is favoring MiECT and this is favoring conventional CPB. So primary outcome was favoring MiECT, but as I said, as we will see later, it did not reach statistical significance. And then you look at all-cause mortality, not much difference. Serious adverse event, same story. Blood transfusion seemed to tend to favor MiECT, and any other blood transfusion was not much difference. The second part of this slide look at ICU stay and hospital stay. And again, a pretty similar picture in the two groups. This is part of secondary endpoint, which is quality of life, utility index. As you can see, the red is the MiECT, the other one, the solid line, is the conventional cardiopulmonary bypass. No much difference. The mean are very much the same. And the same for the VA score, although you may have noticed a significant favor in MiECT. However, if you think that this difference was in the order of 2 or 3 points out of 100, it may be statistically significant, but clinically probably mean not very much. And this is the treatment effect for primary outcome, which were actually decided, pre-specified before the analysis in various subgroups. Again, you got here favoring MiECT, here you got favoring conventional cardiopulmonary bypass, and here the subgroup. You look at difference in age, less than 66 or more than 66, really not much different. Same if you look at sex, male or female, type of operation, CABG, AVR, or CABG and AVR, Euroscore, presence of a preoperative renal failure, hemoglobin level. The bottom line is really there are no great difference in this subgroup between the two techniques. So are these systems, or in particular, is MiECT safe? Of course, it's safe. As you can see, this is for all-cause mortality, and this is for serious adverse event. And of course, the system, as we know, is very safe. And finally, blood product transfused during hospital stay. This is something which gave us a little bit of controversy when writing the manuscript. The bottom line, there was no difference in transfusion during the hospital stay between the two groups, whether you look at red blood cell in terms of unit, or where you look, for example, for fresh frozen, platelets, cryoprecipitate, or when you look at everything of these put all together. So what is the conclusion? The conclusion is MiECT reduces the relative risk of primary outcome event by about 25%. And funny enough, this is what we have hypothesized when we devised the study. The risk of other serious adverse events was similarly reduced. However, and this is the big however, the trial was terminated when we only managed to recruit 30% of the original sample size. We never achieved the sample size. Therefore, the potential benefit of MiECT, in my opinion and in the view of most of the people, remain uncertain. And I will conclude by just giving the list of the center who took part. Many people did a lot of work towards this, and we managed to do a very big study with very little support except for Medtronic and MiECT, to which we are grateful. The paper is just being submitted. I've been told it's back with the editors, and we should know any day now whether it is accepted or whether we need modification or whatever. But once again, I wish to thank you, all the center and all the people who really put a lot of effort to deliver this study. Thank you.
Well, thank you very much, Professor Angelini. Sorry, just to recap a little bit. Maybe I misheard, but did you say that the 25% reduction was not statistically significant, or did I mishear that?
No, it's not statistically significant, but I'm happy to leave it to Professor Reeves to give you more details.
That's curious.
Well, it's a borderline significance. It's close to 0.05. Yeah, I mean, it's less certain than we would like. Yeah, what can I say? Yeah, it's probability.
But I guess conventionally, at least when I read the literature, usually if you're...
Yeah.
I'm sorry?
You take 5%, yes?
Yeah.
0.05? Yeah.
Yeah.
Okay. But, you know, look at the confidence interval, look at the diagram.
Right, and we don't cross zero on the confidence interval.
We don't quite cross zero. If you look at the risk difference, you cross zero. It's complicated to fit the models because the number of events in different centers were uneven, and accounting for the stratification by center, it means the models are difficult to fit.
Right. But the takeaway message, I guess, for anybody reading the paper as published, will end up saying that there was a statistically significant difference between the groups, or it will not.
We report the difference with its confidence interval, period, and it's for the reader to interpret it.
Okay.
We also report in the paper alternative models. You can't expect a trial that finds the same target difference that you hypothesized, and at the outset you said you had to have 3,500 people. Okay, you can't expect the trial to have a very clear conclusion if you get only 30% of the people you were meant to have in the study. It's as good an answer as I think you could have expected to get.
Mm-hmm. Okay. Very good. And I know it's not included in this part of the manuscript. There was also an issue. We're going to look at I think it was the economics or the cost effectiveness. Has that been analyzed as yet, or?
Not yet.
I'm sorry.
Sorry, go ahead, Barney. Go ahead.
Okay, so if you do the cost effectiveness, you will use the EQ5D utility index. The economists use the means, and they do their own empirical probabilistic sampling of the distributions to generate cost effectiveness analysis curves. Now, if there's no difference in that utility and MiECT is slightly more expensive, then the answer, conventional bypass is dominant, because you get no improvement in utility and you cost slightly more with MiECT.
Okay.
And we haven't, we never got a grant to do the cost effectiveness analysis. We don't have an economist on board.
Ah, okay.
I mean, if somebody, the data are there, except that we never collected the micro costs, the social costs around, we don't know what participants spent. We have length of stay, we have levels of care. If somebody wants to do the analysis, that's fine. Yeah. But we didn't have an economist in Bristol.
If somebody wants to do the analysis, we're happy to provide the information, but it's very likely then he won't show anything exciting.
Yeah, okay, reasonable. Any other questions or comments from the audience?
I have only a single comment. I want to thank you for your engagement for the study. It had its ups and downs. We came to a conclusion. It is quite reasonable to state that although we are borderline significance, there are two views to the issue. If you only accomplish 30% of the study population and you have a borderline significance, some would see that as something positive. Of course, a statistician sees that differently. And at the end of the day, it is the reader who, like in any other paper, when I read a paper, I don't take the conclusion of the author as a general rule. I read the paper and make my own conclusions.
Yeah, that's a good point.
And I don't know if we have any of our online colleagues. Dr. Punjabi perhaps wants to make any comments about the...
Thank you. Thank you, Gianni and Barney. I think it was a lot of effort. Thank you for everything. I don't really have much because I'm well aware of the amount of effort that had gone in for analyzing this data set. It may be 30%, but it was still 1,000 patients, which is a lot of data to analyze. And like you said, there was no economist on board. And perhaps even the risk profile was in the baseline characteristics, what I saw was evaluated. So it's unlikely that there would be something in the CABG category, which was around 85%, whether there was any patients with good, moderate, or poor LV function that would have differentiated. But it looks like most of them were of low risk profile with good LV function. Is that correct?
That is one of the problems. The percentage of primary endpoint was relatively low because 85% of cases randomized were straightforward coverage. So you're not expecting. I think the bottom line is if MiECT shows some difference, it will be in the high-risk cases. And this trial didn't recruit high-risk cases for all sorts of reasons, because many centers didn't want to do any AVR because they didn't feel confident, and even less people did AVR in coverage.
Barney, thank you.
So the only evidence we have from that was the subgroup by operation type. Now, there weren't significant differences. It's an exploratory analysis anyhow. But the CABG plus AVR group, in that group, MiECT was less good in that group.
Okay. I was just going to, may I explore one more point,
Yes,
considering
please.
the fact that it was 30% and looking at 30%, but if we had achieved, in excess of 90% recruitment, going by the trends of the 30%, do you think there would have been any divergence? Because the recruitment would probably have continued at a similar fraction and similar population, then even if we would have achieved a 2/3 or nearly 90% recruitment, what would be the divergence? Would there be any? And if there was, what would it be? Having learned the lesson retrospectively, I'm not saying in any way, I'm just exploring what was it that could have made the difference if there was continuation of recruitment. Perhaps it was not a bad thing to stop because this may not have shown anything. Any comments, please? Thank you.
I think we lost Barney. I can answer as much as I can. When we look at the possibility of completing the trial, it would have taken another 4 or 5 years, by which time probably a lot of the technology in one or the other technique would have evolved. One of the problem I think that MiECT is going to experience in the future is then the conventional cardiopulmonary bypass are becoming so good and almost similar to MiECT anyway. So this is the real problem, I think, which is going to happen. So what MiECT has done is help improvement in conventional cardiopulmonary bypass. So the two techniques are almost becoming overlapping each other. And that is the real problem, I think.
And so, Gianni, Gianni, do you think perhaps concentrating on not just, high-risk CABG, but high-risk cardiac surgery may have... Thanks, Barney, for coming back. I don't know if you heard my question before. Thanks.
Well, as Barney said, if you look at the subgroup, in fact, the CABG and AVR was going the other way.
Yeah.
Was going favoring conventional CPB.
And that's why I was trying to understand where would this be beneficial, in which group of patients to better target to look at the actual, benefit. Thanks. Barney.
I don't think we know.
No.
Yeah, I mean, it was a frustration to us that the patients entered into the trial tended to be the low-risk patients, and we tried hard to persuade sites to put their high-risk patients in because we knew they were the ones in which the benefits were hypothesized to be greatest. But it didn't happen.
Yeah. Thank you. I am in no way underestimating the amount of work and the effort that has gone in to try and find that. So thank you very much. Thanks. Back to you, Kyriakos. John.
Well,
Last one.
hit your
Question?
button.
Yeah, just from a perfusion perspective, not concentrating on the results at all. I'd be very interested to look at the actual types, the MiECT types, and to do a sub-analysis on, type 1 versus type 2 versus, or we didn't do type 1, but type 2 versus type 3 and type 4. Would it be possible to be able to do something like that, or and what would I have to do to let you guys give me some data on that? Because we have about 1,000. Well, I guess we got 550 patients basically. So we've got about a couple hundred patients in each category. It'd be very interesting, again, from a perfusionist perspective, to see if there's any difference in those configurations.
I'm just trying to look quickly while you carry on talking about what the numbers were in the different types. Okay.
I've actually got a slide, but go on, Bill. No, you carry on. I may, if I can get the slides, I will. But you carry on. Say what you wanted to say. I don't think.
My hunch is that we simply didn't have that many with, but I'd like to try and confirm that.
Perhaps I can come in.
I think I looked at it. I think there was. I don't know. It was almost. It was
there was
almost even.
176 of type. You're right. It's about a third. 176 type 2, 135 type 3.
Can you see my slide?
Type 4.
No.
Can you see my slides? It's all here.
No, we can't see your
Johnny,
slides.
don't worry. It's a third.
Yeah, I thought it was even. Yeah, third.
I can tell you
Yeah,
then.
well,
50%. Like MiECT type 2 was used in 35%, type 3 in 27%, and type 4 in 38% of patients.
Yeah, so it's about a third each. So, I mean, from my perspective, I wouldn't mind taking a look at that data if you guys think it would be just to do a sub-analysis of that. Would that be something that
Cyril, what analysis is it you want to do?
Well, I want to actually look
at. You want to do?
Yeah, so I would like to look at some outcomes like blood transfusions and don't need to look at primary outcomes like death or anything like that, but more priming and just a lot of perfusion aspects.
And is that just in the MiECT group? You're not trying to do any comparison? Yeah. But just the MiECT group, yeah?
Yeah, just looking at the MiECT.
No problem. I mean, we'll need to set up some kind of data agreement, but it's not a problem sharing the data.
Yeah, okay.
That was one of the original intention. If anybody want to use the data, send us a request and we'll give you the data. One of the things which I have noticed, for example, is that although all the people who were doing MiECT were supposed to be experienced and experience center, there were all sorts of other things used, which in some cases I understand you don't use it in with standard MiECT. For example, cardiotomy suction was used in 36% of the MiECT. Is that normal?
Yeah, no, that should not be normal. So, and that could be another sub-analysis to look at cardiotomy suction versus non-cardiotomy. Those who did versus didn't. I mean, cardiotomy suction, I mean, that's a major point of a MiECT system, is not to use cardiotomy suction.
Perhaps, perhaps in the interest of time, I think this has overall been a very good session. I think, thank you very much, Professor Angelini and Reeves, for actually doing a tremendous amount of work to analyze this data. And I think we're all looking forward to this publication. And because there is such a wealth of data, I think we can potentially look forward to some further sub-analyses in the future. But if there's any further comments from anybody in the audience or the board? Well, in that case, I'd like to thank everyone for their participation in the sessions today. There'll be another full day session again tomorrow. So thank you all very much.
Barney and Gianni, I'll email you guys. I'll email you guys some stuff.
Sure, no problem.
That's okay? Okay, thank you.
Bye.